Okay, guys, welcome to the DM review. This is going to be covering specifically weeks 3 and 4. The slides that I posted for you guys are modification of a little bit of Brady and Lindsay's, and then I added a couple of more things along with some resources that you guys can use. Something to note, I did modify them further and add things that were specifically on our term exam, and I threw that in there just so that you guys could have it. Something to also keep in mind, a little bit of advice before we kind of fully get the ball rolling, is that this DM module is long. And I know many of you guys are panicking, but what you need to know essentially is those essential kind of details from each of the week's material, okay? Whether it's glycolysis, whether it's like, I don't know, you're having struggles with DM anatomy, make sure you guys cover the high yields and leave the finer details to the time when you guys have, I don't know, maybe a couple of minutes to stare at them, etc. As always, my ongoing advice for most of the histo components is going to be review it the night before so that it stays fresh in your brain, right? You have to be able to identify like where you are in the gastrointestinal system, right? Like you have to know if you're looking at the stomach versus, I don't know, you're talking about the duodenum, the ileum, jejunum, etc. Okay. So just be aware of that. Make sure you guys cover your histo because it has shown up and people have kind of like ignored it and kind of being traumatized by it when it does show up. Okay. All right. Continuing on our pathways, guts, and glory. This is part 2, and we're going to cover specifically weeks 3 and 4. Let's get the ball rolling. As always, here's the TPLG. No longer PLG because we're moving away from the school's whole naming scheme. So it's just here's the T now. You guys can follow us directly on Facebook. Here's the QR code to take you to the Facebook. As always, but this is not affiliated with SGU or any sort of academic credit and points that you guys might be receiving for other stuff. Okay. All right, a little bit of quick histo because I got a couple of messages directly about it. Okay, so we're going to start with the liver a little bit in terms of just hepatocytes and how like the whole shebang works. The portal triad, you guys need to know cold, right? You have to know it's composed of the biliary duct, the interlobular vein, and the branch of the hepatic artery. Branch of the hepatic artery only gives like about 25% of the oxygenated blood, whereas the rest of the 75 is only coming from the interlobular vein. And remember, blood kind of flows this way, okay? And bile kind of flows that way, okay? Once you know that, it's just a general principle, but they do ask about the nature of this entire thing. These are sinusoidal kind of capillary systems, so just keep that in mind just to flush out your knowledge. Okay, in terms of units that they prefer to ask you guys about, it's going to be most often the liver acini. That's specifically what they ask in this region is they're going to be asking you if there any sort of, I don't know, poison or toxin that's being released into the body. What would it affect first? Zone 1, right? And then zone 2 is likely going to be affected by yellow fever, which you guys haven't covered, so don't really care about that. And they do ask about zone 3 most often because that's the one that's most prone to ischemia and necrosis, which is something you guys will cover later on in terms 3 and 4. The other thing I wanted to cover in terms of like location wise, a lot of people had an issue with understanding where all of these stuff hang out. Just look at these kind of capillary systems, right? The Kupffer cells are basically your macrophages. They're the macrophages that are specific to the liver, right? Just like how you guys had astrocytes and you had dust cells in the lung. They're, unique type of macrophages that are located throughout your body. And Kupffer cells is one of the important ones in the liver because it does the exact same function as all the other macrophages: engulf, destroy, and get rid of, right? The other thing that they like to ask about is Ito cells, right? I swear to you guys, this is the exact same image we got on our exam. So learn this one very well. And Ito cells are kind of important. Why? Because not only do they store vitamin A, which is a good high yield concept to keep in mind, they also have their ability when damaged to turn into myofibroblasts and eventually make the liver more fibrotic in nature, which isn't good. We want our liver to be nice and functional and patent and et cetera. So, right, fibrosis, we don't want to lay those down. Remember, this is discontinuous epithelium. That's just how it has to be, right? Endothelium has to be like that. And then the bile canaliculi are important, as well as the perisinusoidal space, which they no longer, I guess, call it the space of Dis, but just know that it's also, the other name is perisinusoidal space. The other thing, I know it covered a whole bunch of histo last week, but just make sure you guys covered these two because they did show up on our exam. Gallbladder, it didn't show up too much. We only, I think, had 1 or 2 questions on it. Essentially, these are Rokitansky-Ashkoff sinuses. These are false, essentially, lumens, right? Like you guys are seeing these false lumens that are hanging out. Just know that they're just invaginations into the mucosa. And most often they're involved with hyperplasia, herniation of the epithelium, and they can actually precipitate into gallstones, right? Any sort of bacterial infection, because remember, these are all walled off spaces. Bacteria can still replicate in here, and then that can have precipitating action with your gallstones, right? Formation, and eventually, cholestasis, so on and so forth. Okay, pancreas. They like to know about the pancreas a lot, and I'm going to cover it a little bit in GI physiology, and we'll kind of get into the finer details of it. But you do need to know CCK, because remember, it's basically inducing the acinar cells at this location to release these proenzymes, right? The biggest kahuna of the whole family is trypsinogen, converts into trypsin. It goes downstream and cleaves a whole bunch of other components, which are all outlined in GI physiology. Secretion is the other one, right? Induces the intercalated ducts to secrete large quantities of enzyme-poor alkaline fluid. Why do we need these alkaline fluid? You got to balance your overall charge as your body's kind of bringing in more acidic content from the stomach, right? You got to make sure if it's balanced out that you can do the proper absorption. We don't want anything to be either too acidic or too basic. No one likes anything basic, okay? So just a future advice also. As always, sympathetic and parasympathetic, you guys know. Make sure you guys review those DLAs. I covered a little bit of them last week, but we also covered a lot of the anatomy and the physiology components associated with the sympathetics and the parasympathetics. What they also like to ask about the pancreas is the endocrine functions. This is a cumulative question that they like to typically throw in. Okay, how I remembered it is very simple. They had an immunofluorescent image of this, islets of Langerhans, and then they asked us what type of cells are located in the periphery, and the answer literally was just alpha cells, right? How I remembered is that the alpha cells protect all of the betas. So the betas are more like interspersed, alphas protect the beta, so they're on the outer edge protecting the betas, okay? Little dumb way to remember it, but it's helpful in the long run. Okay. I had to truncate the GI physiology because I covered a good chunk of it last time. So if you guys see a whole bunch of slides that are on there that feels like I'm not covering it, it's because I covered it last week. Feel free to watch the recording, but let's kind of get started. So the esophageal manometry, this one threw a lot of people off because we were like, there's no way they're going to ask us these questions. But they did, and you had to know what was happening at each location. So what essentially is happening is peristaltic waves, right? But remember, the peristaltic waves have to change based off of where you are in the esophageal tract, right? You guys can see when you see this sufficient spikes that you are essentially, relaxing, and then you have these bimodal kind of changes. That's showing the actual contractile portion, and that's when the bolus is able to move along, right? It's not the contracted portion that the food is stuck in, it's actually right here. So those waves essentially go through and through so that they can eventually reach to the lower sphincter. The lower sphincter is kind of unique because when you're going through this, you have to realize like peristaltic waves are doing these like large spikes, but you actually need at the lower sphincter a drop, right? You need those muscles, smooth muscles to essentially relax so that, your food can essentially just drop into your stomach, right? Especially the fundic region where a lot of important physiological factors take place, right? So the relaxation is mediated by nitric oxide. You guys have covered that in FTM. and you guys have probably covered it again during the physiology lectures. Obviously, acetylcholine, think about this. A lot of these components are driven by the vagus nerve, right? The esophagus, as well as a lot of your digestive components, vagus nerve, but it has its own internal peristaltic motion because remember, smooth muscles can run off of their own kind of system. Okay. GIT motor activities and their function. Essentially, what you need to know is that there are three kind of components to this. There is segmentation, right, which is super important. It is non-propulsion. You're not moving the food along. You're just mixing and churning. That's important. Peristaltic waves propel the food. So I think P and P go together. Peristaltic propulsion, right? Caudally, meaning it's going towards like, down the digestive tract. Reservoir function, this is just delayed, right? Like it's basically hits a roadblock at the sphincter level so that even if you had any sort of peristaltic movements, your stomach can just essentially just hold on to the food and not allow for it to pass on to the intestinal components and eventually being brought in for absorption. Okay, GI motility, important. There's tonic contractions, there's phasic contractions. Tonic is just sustained for minutes to hours. Know that, right? It's minutes to hours versus phasic contractions are kind of cyclic in nature and they only last seconds, right? Location for them is also going to be important. So lower esophageal, pyloric, ileocecal, and internal anal canal all do tonic, whereas phasic is often seen with the esophagus, gastric antrum, and small intestines, right? And the goal of it is to essentially lead to what we were talking about, and a lot of questions were raised about the whole slow wave and all that jazz, and I'm going to cover that in a bit. Okay. Regulation, right? You guys know this. It's primarily parasympathetic in nature because remember, rest and digest, parasympathetic. It's the same principle now being applied. Now, if you had more of opposite kind of system, right? Opposing systems where you're doing more relaxation, that's actually driven by sympathetics, right? VIP, you guys remember your VIP, which is vasoactive, I think, protein. It essentially does the exact kind of same function as NO and relaxes the kind of smooth muscle movements, and it causes decreased contraction and motility. So there's going to be decreased peristaltic waves, right? Obviously, there's two systems when you're thinking about this, and I covered this last time. There's the extrinsic coming from the central nervous system, and then you have your intrinsic coming specifically from the localized tissue, right? The neurons that are localized here. And those are all neurons that you guys know because they're all coming from neural crest cells, tie in those big concepts together. Okay, two main components. So this is why, especially growing up in an immigrant household, my mom would always tell you to drink a nice cup of water before you have any sort of breakfast in the morning. It's because there's some science to it, ironically. Your interdigestive kind of system has a relaxed state where it can't just, nothing in our body just stays still, right? It has to still keep doing its primary function, which is making sure it cleans out your digestive tract while you're not eating, right? Your MMMC, which is the migrating motor complex, basically cleans out your stomach and your gut during fasting. This is why they tell you to have a cup of water in the morning before, you have a meal, because the MMMC isn't really going to be involved with the actual digestive component. So most of the food that you're putting in isn't going to do anything. It's just going to be passed along, right? So it's cleaning out your system, AKA chug some water before you, have a bowl of cereal or something. Okay. Now, obviously you guys know your fed state very well because you've covered it so much in depth. Segmentation, peristalsis. Segmentation holds onto the food, mixes and churns it, right? It's the mechanical nature of breaking apart food, whereas peristalsis is going to propel, right? Peristalsis, PNP, propel. Cool. Characteristics of MMMC, right? The functional role, right? Prevent bacterial overgrowth. If anything stays still for long, things will start growing and it's not good, right? And the propulsion of undigested material such as cellulose and other stuff that you can't really break apart helps with propulsion and getting stuff through. Obviously, this is driven by both the MMC, which has an independent function from the ANS. So keep that in mind. It's coming specifically from the ENS. So if there's any sort of questions regarding ANS for the MMMC, that doesn't happen. Key key hormone that drives this entire process. Motilin, if you see a whole bunch of M's, right, just keep in mind MMC, motilin, and that's going to be essential. Okay. Slow waves. Now, the slow waves are basically just natural waves that are going in sequence based off of what's thrown at it. And they originate from the cells of Cajal, and they're basically the pacemaker. Just like how your heart has a pacemaker system, these are driven by the mechanical pressure that you're putting on the stomach, right? Stomach or other parts of your digestive tract. When they basically get stretched and change, they allow for the action potential to propagate through, right? It's like kind of like a wave, right? If obviously they're going to be active basally, but when you add more food or other things that adds mechanical pressure, it allows for the propulsion of food to happen naturally. Okay. What kind of threw me off when I was going through this the first time around was that a lot of it is driven by summation in nature, right? Most of the times the slow waves are just going, right? They're kind of running through. But as you're doing as you're doing the process of bringing food in, it's stretching these cells, right? And that's going to allow for the summative nature of them, and eventually they're going to hit threshold and they're going to spike, right? And that allows for this whole thing to propagate, right? Calcium channels open, right? The whole action potential is generated, smooth muscle contraction. Remember, this is calcium driven, right? As compared to what we see in a lot of other places, which is sodium driven, okay? All right, motility, right, and versus reservoir function. Most of the food, if you guys have it in terms of reservoir function, is going to be hanging out in the fundic region. This is really important because the fundic region allows for not only receptive relaxation, you will also have potential opportunity to have downstream effects on your I'm blanking on the word, but the amount of hydrochloric acid that's released from your parietal cells and eventually leading to the breakdown of food, right? At this point, you want to close into the pyloric valve, right? You want to close that in because you want segmentation as well as peristalsis to do their magic, right? There are peristaltic ways, right, happening because food is moving into the more the belly of the actual stomach, and where segmentation can then process it along and eventually lead it into the intestines. Okay, motility, haustras have like large segmentation up here with the contraction of the colon, right? That's haustra shuttling, and that shuttling allows for things to kind of stay there longer as compared to your mass movements, right? The mass movements help move fecal material longer distance, versus shuttling helps more segmentation and let the food eventually be absorbed, as well as any sort of water, ions, and other things to be absorbed back in. Because remember, we've already passed through the small intestines where a good chunk of things are absorbed, okay? The transit time, they actually focused in on this a little bit in terms of question-wise, so I would pay attention to what was said in lecture a lot. But as you can see, the transit time and the slow waves slowly start correlating, right, as you're going through. So you can imagine the esophagus proximal transit time is very short. You don't want anything there. When you get to the stomach, it's going to be a little bit longer because you're doing a lot of segmentation as well as potentially storage of food. When you get eventually into the small intestines, right, transit time is much longer, 7 to 9 hours, and the slow wave is about 11 to 12 minutes. It makes sense, right? Think about how long it takes for food to eventually pass through our digestive system. Of course, this is all like giving you in broad pictures. Some folks are fast metabolizers, some people are slow metabolizers. There's a whole bunch of individual kind of components adding to this, depending on food and diet and what you intake. This GI reflex lecture was really weird because they never asked us about anything other than the gastrocolic, which just tells you that when food is brought in, more food needs to be released, right? That's it. It's the gastrocolic. Gastro is talking about the stomach component, more food coming in. Colic kind of component telling you that the large intestine should push out components from the, any sort of fecal material needs to be put into the sigmoid colon and eventually released out into the world. Okay, sphincters, essential ones to know. I covered a little bit of the sphincter components as well as like the narrowing. Just know that there are questions about that. For these, they specifically ask more about the pyloric because there's a couple of issues. You guys know if there's pyloric stenosis, there's like olive-like thing. If you're doing the physical examination, that's a buzzword. Sphincter of Oddi, they really don't care about it too much, but it is good buzzword for telling you some kind of um, any sort of gallstones that are being thrown in the common bile duct. Okay, ileocecal, they will ask you in terms of absorption, and I'm going to cover that in a bit. And then, of course, anal canal, of course, it's going to have internal, external, right? There's like the sympathetic, no, not sympathetic. There is the somatic innervation, and then there's, of course, the more of the autonomic components that are involved with that region. Okay, now kind of a quick summary of salivation and how it works. It's basically the process by which, when you guys covered your salivary ducts and glands, this is how they essentially work. When you are doing like really quick kind of pass through of this duct, you're not allowing for sufficient levels of sodium and chloride to be pushed out. So there's going to be more isotonic, so that if there's increased salivary secretion, it's more isotonic in terms of speed of conduction. If it's slower, it's going to become more hypotonic. So that's going to be important because when you're looking at this graph, which I believe they asked us one question about this, is how the flow rate depends on the salivary composition, right? As I mentioned, if it's slow, right, it's going to be more hypotonic in nature because more of the NaCl can be essentially pushed out and leading to a more hypotonic state. When you're doing a whole bunch of salivary like secretion, right, and it's very quick, right? Think of read your x-axis. You can see how fast it's going, right? Milliliters per minute. That's a whole bunch. So it's going to be more isotonic in nature. So increased flow, increased tonicity. Okay. Gastric secretions, this one is a little important because it tells you why you actually go into a food coma. Just kidding. But in all fairness, there's a little bit of science as to why this is happening. Nothing in our body is just randomly made, right? There's no magical way that you get hydrogen ions to appear out of nowhere. It's all done by the enzymes that you guys learned back in term 1, such as carbonic anhydrase, something me and Priya know very well from FTCM as well. Carbonic anhydrase is one of the critical enzymes that takes everything that we get naturally, such as carbon dioxide and H2O, and makes it into bicarb and H+ ions, right? H+ ions have to be brought in somewhere, and we get these naturally, but in the process of doing that, a whole bunch of bicarb has to be released into the blood. So what happens is you kind of become basic after you eat. I mean, it's kind of funny because everyone's basic after they eat. Everyone wants to go into a food coma. It's called the alkaline tide. It's an increase in venous blood pH because it makes sense. Whenever you're doing any sort of balancing, an acid-base balancing, bicarb has to go somewhere. It can't just hang out with your H+ ions, because remember, your parietal cells have to use this H+ ions to create hydrochloric acid, right? So your blood has to take up some of this bicarb and you become a little basic. But don't worry, it's not an acid-base disorder in any sense, because there is a rebalancing of these equations when you get into the small intestines, okay? And I'll show you guys that. Obviously, 2 things to know with the parietal cells. Know that it is hydrochloric acid secretion primarily. And the other thing that they do is intrinsic factor, which is something we're going to cover a little bit later, okay? In terms of gastric secretion kind of roles, there are different phases. They did ask about this in terms of our exam. There's the cephalic, there's the gastric, and the intestinal. The cephalic is the one that is just straight up like, you're daydreaming about food that you're going to be having for lunch. Okay. It's a glorious time, but it's nothing mechanically happening. Of course, you could have some chewing and swallowing kind of components that could, make this more predominant. But what happens is it leads to the stimulation of acetylcholine, right? And gastrin. Guess what? You guys know what acetylcholine and gastrin does, because they're all part of your parasympathetic as well as your G cells. Your G cells are going to stimulate your parietal cells to release more hydrochloric acid, preparing for the food that's about to come in. That's the cephalic phase. The gastric phase is more driven by the fundic distension, right? Food comes in from the esophagus, spreads the stomach a little further out, right? The rugae have to like spread out, right? If you guys remember your anatomy for your stomach, the rugae spread out. And the local ENS basically reflexively allow for the release of acetylcholine and gastrin, right? Parasympathetic as well as the local enteric nervous system basically responding to this. Of course, when you get to the intestines, that one is driven primarily by the proteins, right? And it's basically it's like a litmus test at the duodenal level and tells you that, hey, there's food coming in that's being digested. Let's start taking up these amino acids. And that's primarily done by a lot of the, the eye cells, secretins, and all of those things that are eventually going to be released in order to allow for the protein digestion and metabolism. Okay, balancing of the scales. This is important, right? I talked to you guys about how the equations have to be balanced out. Eventually, this is what happens, right? The gastroduodenal barrier basically keeps an eye on everything that's coming in, right, from your stomach, right? Whether you chug some alcohol, you took some NSAIDs, bile acids, ischemia, smoking, all of these stuff have to be balanced out with sufficient levels of, I don't know, bicarb, mucus, blood flow, growth factors, and other things to make sure that the gastroduodenal components stay nice and normal so that nothing cancerous can potentially happen. Okay, now, what happens if you're stressed out and you're having peptic ulcers all the time? Boom, you get omeprazole. That's what Dr. Dasso told us. So I don't know if you guys have had him yet, but he's fantastic. There are a couple of drugs that work at different locations, right? HK-ATPase, that basically, exchanges hydrogen for potassium, right? Potassium gets brought in, hydrogen gets pushed out so that you can make hydrochloric acid. As always, keep in mind omeprazole and lansoprazole. I cannot say half of these drugs' names. But what essentially happens is they inhibit this pump. They are proton pump inhibitors, right? Now, what happens with histamine? This is the reason why they tell you not to be too stressed out. Histamine actually aggravates this pathway, right? Histamine is an upregulator via cyclic AMP. I covered this with you guys last time, and you can give them simantadine, ranitidine, which are all drugs that us T4s covered very recently and are quite traumatized by. You can also give them muscarinic antagonists such as atropine, right? I told you guys, remember parasympathetic, rest and digest. So atropine is a muscarinic antagonist. So parasympathetics are going to be downregulated. Obviously, you're not just shoveling atropine down a patient's throat whenever they have like a, I don't know, peptic ulcer. So don't do that. Don't give them atropine. That'd be weird. Okay, gastrin receptor blockers such as benzotript. It's not often used. Most of the time they go with a proton pump inhibitor like this, or maybe a histamine blocker if you're like too like stress driven. But that's why, relax once in a while, guys, so that you guys don't develop those peptic ulcers. Pancreatic secretions, important to know, secretin, CCK, and acetylcholine, okay? Obviously, you guys know this very well, acetylcholine, because you guys have heard it time and time again. Let's cover secretin, CCK. Secretin is at, believe it or not, S and S go together. So S cells of the duodenum help secrete secretin, right? They are in response to the acids that you have created at the stomach level. When they get hit with the acids, right, hydrochloric acid, and then the dissociated H+ ions, they allow for increased bicarb secretion, right? When the bicarb meets up with the H+, guess what? Carbonic anhydrase does its magic and converts it back into carbon dioxide and water. Carbon dioxide, believe it or not, is one of those things that is involved with your overall digestive system. Carbon dioxide is essential, and eventually it will be, right, it's gases, right? All the gases that you're associated with. CCK, eye cells, right, is important. Keep in mind, it's eye cells. CCK is eye cells. Don't put anything else. Don't put C cells or anything that they give you in terms of tripping you up. It also does a similar function, but it's in response to, guess what, amino acids, peptide sequences, and fatty acids. Why? Because CCK is involved with eventual release at the gallbladder sphincter to relax it and allow for your bile acids to come down your common bile duct and eventually help you take up the fatty acids that are being brought in. Okay, because remember, you can't just bring in stuff very quickly with certain kind of components that's in your diet. Obviously, you have to use bicarb too to balance out this kind of acidic environment. So important to know that. Okay, I told you guys we have to rebalance the equation. So here it is. Guess what? In the intestines, the same process happens. You take bicarb, produce bicarbonic anhydrase, you combine any sort of chlorine, right? Cellular chloride levels. It's brought in by CFTR, which is a really important thing because CFTR, guess what? Cystic fibrosis. And now you guys understand the full mechanism by which you have, let's say, why the baby can't pass its meconium, because the meconium is so darn dry. Meconium is just the baby's first poop, okay? Just so everyone can kind of be on the same page. It also messes up with the NKCC transporters, which me and Priya have learned again for wonderful when did we cover it? CPR, as well as in term 4. So these are all important components that are brought back in of the chloride levels. Sodium and water, it's passively brought in because you have paracellular kind of junctions that allow for it, right? They're relatively easier to set up and bring in. And of course, your H plus gets balanced in with the bicarb and gets converted back with carbonic anhydrase into carbon dioxide and water, right? Essentially, the exact same process that happened at the stomach is now being rebalanced at the intestine. So you never become acidotic or alkalotic in this entire process. Partially, I say that with kind of a partial kind of component. Okay, as always, low flow, it's mainly NaCl. We're talking about the pancreas. Don't get it twisted with what happens with saliva. Low flow, it's mainly NaCl, whereas high flow, it's Na bicarb with ductal cells, right? Just know those and you should be good. I told you guys, CFTR, cystic fibrosis, essentially what you need to know is that the meconium gets dried out, AKA you're not able to bring in, you're not able to pass the stool, as well as you're not able to break apart a lot of the different enzymes, because what happens is the chloride channels get messed up, the lumen negativity kind of gets thrown out of whack, as well as your movement, right? You're setting up the gradient, your gradient kind of gets thrown off because you have balancing charges. So your sodium and water don't really want to leave the luminal side, and they just want to just get out, okay? Which is why, babies will have digestive issues with CFTR and cystic fibrosis. Okay, this is kind of a summary of the intestinal kind of phases. Just know these in terms of what they release, and you should be good. Vagal reflux is acetylcholine, right? It makes sense, right? Parasympathetic components. I cell, duodenal, CCK, S cells, secretion. You should be good. Okay, intestinal absorption. This is a walkthrough of how everything gets balanced out. Obviously, you guys know now that it's a whole acid-base rebalancing component. Initially in the small intestines, the net secretion is bicarb, right? Because we're taking a whole bunch of H plus and we need to combine it with bicarb to eventually neutralize it and bring back in any sort of water and carbon dioxide just gets gotten rid of via flatulence and other kind of fecal matter pass through, okay? And then in the large intestines, net secretion is still going to be bicarb and potassium, right? Potassium, you're going to need it eventually to, you're going to reabsorb it back in, but I'll show you guys that later on. Okay, very simple. Diarrhea, what happens? You lose a whole bunch of bicarb. What do you become? Metabolic acidosis, right? Very simple. Anything that's happening with the digestive system, metabolic acidosis, right? Typically, if you are vomiting is going to put you in metabolic alkalosis. I literally drew a line in my DM module notes, and I said, stomach and above, you're going to have typically alkalosis. Anything below, in terms of diarrhea, it's going to be acidosis, right? Metabolic. So, all right, diarrhea and potassium balancing. It can lead to hypokalemia because what did I tell you guys? In the large intestines, bicarb gets released out as well as your potassium, right? It's because you're doing an exchanging process. You're setting up a gradient of bringing in more sodium because you're using N NK kind of antiporters, and that NK antiporters allow for you to essentially pull in more water into the cell and do the absorption. That's why you can basically, it helps create the stool that you're eventually going to pass. Okay, here's the summary. I told you guys acidosis, right? Loss of bicarb, it's going to put you into acidosis. Any sort of anything above, such as with vomiting, it's going to be metabolic alkalosis. And once again, diarrhea is also going to put you in hypokalemia. Hypokalemia is bad. This is something we also learned again in term 4. Cardiac arrhythmias, guys. Priya knows that very well, and we have drugs for it now. We're all traumatized by term 4, if you guys can't tell. Okay, this is a very broad overview of what absorptive kind of components. As you guys can see, a good chunk of the stuff gets absorbed in the jejunum. The duodenum is basically helping you set up the process by which you are doing a lot of absorption of components such as carbohydrates, amino acids, and lipids in the jejunum, right? Whereas in the ileum, you're going to primarily do is bring in a couple of other components, right? Mostly water, and then there's also absorption of certain elements such as vitamin B12. Guess what, guys? Intrinsic factors from the parietal cells are bringing a full swing into this kind of component, vitamin C, and then bile acids. Guess what? Those bile acids we're going to cover. Okay. Here's another broad overview. I wanted to show you guys all the different cells that are involved and what they do in terms of hydrochloric acid secretion, right? They can ask you about any of these, but they preferentially like to ask you about typically your secretin and your CCK, which is your eye cells. Okay, know those very well. They might give you 1 or 2 questions on histamine and gastrin, but it's very simple because you guys can typically work through the logic there. But I just wanted to point those 2 out. Here is like the full pathway of drugs and things and how they work. I just threw it in because you guys needed a bigger picture of everything instead of just looking at everything in a silo. So feel free to run through it. Here's atropine that I mentioned to you guys. Here are the H2 blockers that I mentioned, somatostatin analogs, prostaglandins, right? This is why we don't take NSAIDs, right, on empty stomach, because they shut down your prostaglandins, right? So you have to give them artificial or analog prostaglandins in order to inhibit excess gastric secretion, right? Because remember, if this gets shut down, there's upregulation of your GS process, more cyclic AMP, more proton pump activity, and boom, you get a whole bunch of hydrochloric and you have peptic ulcers now. Congratulations. Proton pump inhibitors are the most expensive ones. They're typically for your bad and bougie patients. Omeprazole, all the prazols are bad and bougie and they cost a lot of money, but they are very good at what they do, right? They're helpful because they don't typically have too many contraindications. All right, digestion and metabolism. Let's get a little bit of this stuff that's from Trotz's lecture out of the way. Salivary amylase is very important. Don't get it twisted. It's alpha-1 for glycosidic bond breakage of starch and glycogen. It's basically the starting point by which you break apart carbohydrates, okay? Breaking apart, you're not doing any digestion at your mouth, believe it or not. Lingual lipases allow for lipids to be kind of digested and released into the oral cavity, primarily via swallowing. There's obviously you're doing mechanical breaking down of stuff too, right? That's what they typically say is like a food bolus, right? It's basically this ball that you generate as you are breaking apart and chewing food. Digestion in the stomach, very simple. Think of your chief cells and your parietal cells. And what you need to know is that your hydrochloric acid is just one player in this picture. It takes the pepsinogen, right? Whenever you see an O-gin, it's a zymogen. Zymogens are inactive and they get cleaved into an active form, which is pepsin. If you guys remember that, you guys are solid. Okay, moving along to your endocrine functions. What did I tell you guys? 2 things to know cold is secretin and CCK. Okay, they help neutralize the whole bunch of acid that you're throwing into your system. Let's look at cholecystokinin. I love Trotz because she likes breaking apart her words and it makes my life less intense trying to learn Latin and Greek in the same kind of medical school curriculum. Cole is talking about bile. Cysto is talking about this, the kind of the gallbladder sac, and the kinin is movement. So it releases bile from the gallbladder. Very simple. Enteropeptidases get thrown into the duodenum. The secretion of pancreatic enzymes, zymogens, and other stuff essentially allow for breakage of those said proteins further and eventual metabolism, right? Bile also helps with bringing in cholesterol, lipids, and fats and other components. So keep that in mind. Okay, enteropeptidases, what do? The essential one to know cold is trypsin. Okay, trypsin is essentially converted from trypsinogen to trypsin and helps cleave all of this jazz that you guys are seeing below, right? Super important. It's activated, also activates lipid digestion via phospholipase A2, right? And that helps essentially bring in lipids. Big picture, you guys know this very much so now. Obviously, small intestines and stomach, right? Your stomach is primarily involved in breaking apart stuff. There's not full-fledged digestion happening. In small intestines and the brush borders and the intestinal mucosa help bring in a good chunk of everything that you need, right? Whether it's carbohydrates, proteins, lipids, fat, and all those components are brought in those components, in those specific parts of the GIT. Okay, trypsin or trypsinogen to trypsin is basically cleaved by enteropeptidases, right? Enteropeptidases is another thing to keep in mind. That's very critical. And where does it all go? It feeds into the common, well, not really the common bile duct. It goes into the papillae, and that papillae, via the sphincter of Oddi, which is going to relax due to CCK release, it's going to allow for all of this beautiful juices to be brought into the small intestines. Okay, once again, digestion and metabolism of carbohydrates, right? Salivary amylase breaks apart stuff. Carbohydrates, digestion doesn't really happen at the stomach. Once again, small intestines, brush borders, intestinal mucosa are all going to be involved with carbohydrate intake. Lipids, guess what? We can't really bring in lipids. What do we need? Lipids to be brought in via, let's say, bile, right? Bile essentially takes these nice globules and wraps them around in a nice bow and helps allow for these cells to be essentially take them in. So I'm going to go over this a little bit in detail, but not right now. Transportation, obviously, like what you need to know is it's bile salts are derived from cholesterol, right? So this is why we want to monitor our patients' levels of cholesterol and why we don't like, in terms of like gallstone precipitation, you don't like tell your patients to have like a nice big burger and fries and a milkshake and like a dozen pound of like, I don't know, pizzas or something. Okay. So important to know that it's cholesterol driven. It's conjugated into bilirubin in the bile from the liver to the duodenum, and then it's reconverted back into bile salts and then brought back in, right? There's 2 levels of conjugation. We're going to cover both of those. Functions, right? Small intestines, it emulsifies dietary lipids. That's what you need to know. It creates essentially these protective structures. These structures allow for them to basically be phagocytized in. They are emulsified droplets. Pancreatic lipases are inhibited by drug auristatin. Why we use auristatin is that it doesn't allow for the proper cleavage, right, it doesn't allow for the proper cleavage of certain zymogens, and that essentially doesn't allow for these bile acids to be created into sufficient levels. So guess what? The patients are actually going to lose weight because the fat droplets have to, it can be brought back in the stomach, and not in the stomach, in the duodenum, and eventually gets passed on into the stool, aka what happens is you get steatorrhea and weight loss. Okay. Life is all about give and take, guys. Guess what? Function of bile salts, like I told you guys, it's a mixed mishal, right? Helps bring lipids into the mucosal cells. Transportation, it's typically done by free cholesterol. Give me 1 second. I'm going to sip some tea. Get it? Here's the tea. No, my voice was going out. Delivery of bile salts is typically done at the small intestinal level in terms of bringing these dietary lipids in. Now, what you need to know is that the formation of these micelles help bring these lipids into the intestinal mucosa. The release about 5% of the bile salts into the feces, but most of the time we actually bring back in these bile salts and the conjugated bile acids. Possible causes of steatorrhea, guys, you guys know this very much. So now you have liver damage because remember cholesterol, it's converted into these bile salts at the liver component. Bile ducts gets obstructed via gallstones, cholestasis, pancreatic tumor. What happens with the pancreatic tumor is that you have a ductal blockage of the pancreatic head, right? So that doesn't allow for your common bile duct to essentially drain out. So it's once again a mechanical blockage. Okay, defects in the pancreatic juices, once again important, you need the pancreatic juices. So what's going to be affected with cystic fibrosis? Remember, we talked about your cftr and why that's important in terms of your pancreas and your exocrine components. And of course, bicarb is going to throw it out of whack. So your food and everything that you've digested or broken apart mechanically is now more acidic and can't really be brought back in. So you'd have to maintain a close eye on the patient's stomach. Gallstones, right? I hate to say this, and I think Dr. Marshall kind of taught it to us like this. It's like the 4 F's that typically precipitate any sort of gallstone: fat, female, 40, fertile. I'm so sorry if I offend anyone. Please, it's not me. It's SGU. Blame them. Okay. Thank you for my TED Talk. Liver conjugates the bile acids with glycine and taurine, right? Releases in forms of bile salts. Now, this is the whole conjugation, right? You guys remember your glycine and taurine are essentially combined with these bile acids to get their unique names. Obviously, this helps you bring stuff in, such as those lipids, but don't even trip about it. They get deconjugated and then they get conjugated again, and eventually they get brought back in via our circulatory portal system. So keep that in mind. They like to ask about the portal system. Okay, there are very few things I tell you guys to memorize cold. It's this, know this very well, because they like asking about this, and they literally just ask us in the secondary kind of transit of your bile acids, what is the conjugated form? So you have to remember the secondary bile acids are these, right? So this is happening in the intestines, and they get converted back into these bile salts, which then can be brought into the entire digestive component. So terminal ileum, right? That's when you do most of the reabsorption. So if there's any sort of ileocecal issue, then this part gets messed up, okay? That reabsorption gets messed up. So you're gonna find increased levels of bile acids and salts in your fecal matter, okay? Guess what? Like everything else in life, everything gets bound to albumin, and that's how it gets brought back in, because remember, these are acids and salts, so they have charges on them. We can't transport anything that's charged, so it needs to be bound to something that can neutralize it and allow for things to pass through. As always, our number one player in life, albumin. Got our back since day one. All right, cholesterol. This is what I wish I was doing right now, burgers. Okay, just kidding. Function of cholesterol. You guys have known cholesterol pretty much your whole life. There's good cholesterol, there's bad cholesterol. What you need to know is that when you're going through the cholesterol pathway, there is very few kind of components that you need to memorize. And I'm going to tell you guys the essential enzymes and things to keep in mind. Okay. As always, cholesterol, why is it so important? It's one of the kind of the essential factors of when you make vitamin D, right? Because remember, 7-dihydroxycholecalciferol is essential, right? It's a form of vitamin D that has yet to be like sufficiently enzymatically changed to lead to your active form, which is dihydroxycholecalciferol, which is important for bringing in your calcium. Okay. Once again, it also helps with your cell membrane fluidity. You guys cover that in FTM. I'm not going to rehash it, but they're also important for your steroid hormones, because remember, cholesterol makes up everything that you know with your testosterone, estrogen, progesterone, cortisol. So all of your mineralocorticoid, glucocorticoids, and all of the other stuff, as well as your androgens. So keep that in mind. All right, guess what? Insulin. What do you guys think? Is insulin going to upregulate the activity of this whole pathway? Yeah, because it's fatty acids and cholesterol you're going to store, right? If you had a nice big meal with burgers and fries and yummy, cholesterol being brought into your digestive system, obviously you're going to want to store some of it. So what is the thing that you need to know? The essential thing that they always like to ask about is HMG-CoA reductase. Whenever we have an HMG-CoA reductase thing, they always ask about the rate limiting enzyme. So whenever you think of cholesterol, start thinking of this and know that it's essential in taking this cholesterol and further converting it into storable form of your fatty acids, triglycerides, and all those other components. Okay, overview of the synthesis. I would tell you guys to whiteboard this out one time and never look at it ever again. Okay, you might get one or two questions on this portion and maybe this portion. That's it. Okay, there's like literally just two things you need to know about this whole pathway. Because guess what? HMG-CoA reductase, the only thing that really helps with the, well, is a competitive inhibitor of it is statins, right? Statins are just an analog and it's reversible competitive inhibition, okay? Don't put irreversible, your patient's not gonna die, but still you gotta know that one code. It's a fundamental biochemistry concept. It's a reversible competitive inhibitor, okay, your statins. The other thing to know is that cumulative question that they asked us was lancesterol to cholesterol, right? When you guys are thinking of cholesterol, remember they're stored as inclusion bodies in your cells, right? In your adipocytes and other places, right? That remember the whole signet ring thing that you guys covered back in the day, as well as you guys probably covered in this module. What you need to remember is that it needs to be brought into the mitochondria so that you can eventually break it apart and make your essential steroid hormones, right? Especially in your adrenal cortex. So think about it this way. What is the essential thing that you need to do in terms of taking it from the storage site and bringing it into the mitochondria? Guess what? It's a thing that you guys covered before. It's called STAR, right? So that's a nice cumulative question right there. Keep that in mind. That was a question that they asked us on our exam. Okay, same thing. Know this part cold, and they like to ask questions about that. What else did I wanted to say about this? There was one component that tested my knowledge, but it seems to elude me. Oh, this one. They ask one more question. This is what I was trying to tell you guys about. This part they like to ask in terms of SLOS, which is Smith-Lemli-Optez syndrome. It's deficiency of 7-dihydroxycholesterol reductase. 7-dihydrocholesterol reductase, I can't pronounce words now, is responsible for the final step, right, of converting from lancesterol to cholesterol, right? It's the correct formation. So keep that in mind whenever you guys are going through this. They like to ask a question about this. It's a deficiency and it can lead to the typical presentation. Whenever you guys are guessing anything in terms of inheritance pattern, it's always autosomal recessive a good chunk of the times. And another random kind of information, I don't know if they asked us this specifically, but is that cholesterol can help with a lot of the peripheral tissue level changes, and you can address it very quickly, but the central nervous system cannot really recover from this because you can get microcephaly, right? Because you need those essential cholesterols to make up a lot of your, if you guys can think back to your neuronal kind of breakdown, the each kind of Schwann cells are basically lipids and fats kind of protecting it. It's an insulation kind of component.
Sorry, Kish, I forget that. What was that cumulative question that you were talking about with the cholesterol and cholesterol again? Something about starvation or something.
It's STAR. So you need to know this enzyme. Well, in terms of taking the cholesterol to eventually create your steroid hormones, it was STAR, which is it essentially allows for the cholesterol to be brought into the mitochondria and properly then activated into the steroid pathway that you guys learned with the 7-dihydroxy kind of enzymatic kind of changes that you get with creating your mineralocorticoids, glucocorticoids, and weak androgens.
Thank you.
Okay. All right, degradation of cholesterol, guess what? It requires essentially carbon dioxide and water and its conversion into bile acids, right? This is why we need cholesterol in our diet. We need good cholesterol. You can always kind of rely on the whole, not doing any carbohydrates thing, but you can always have to make sure you have sufficient levels of cholesterol. Okay. As always, a good chunk of the bile acids and stuff is absorbed back in. But eventually, in terms of elimination, any sort of excess cholesterol is deposited into the fecal matter and lost in feces, right? It's also important because you need these bile acids to bring those fat-soluble vitamins. What are your fat-soluble? A, D, K, right? ADEK, right? That's how I remembered it. It's an MCAT knowledge as well as a cumulative knowledge to keep in mind. Here it is, precipitating factors of cholesterol, right? If you have a patient come in with a nice juicy burger that they've had in the last 24 hours and they have like very sharp pain. Okay, important to know this one, guys, localized pain, right? That's more somatic in nature is going to be localized to the right upper quadrant if you're asking the patient for physical examination components. You can also get it so far irritated that it will go to the mid kind of superior umbilical region. And if it gets so bad that it messes with the phrenic nerve, it will have right-sided shoulder pain as well. Just something to keep in mind. If there's any sort of gallbladder level issue and an obstruction, guess what? Steatorrhea, right, is foul-smelling loss of your fats and your cholesterol and lipids. Jaundice can typically be the identifiable thing. Sclera ictus, like if you see, your patient's eyes, the scleral component being turned yellow, it's because these bile acids they don't know where to go, so they get deposited into connective tissue. Potential causes, right? They gave you guys a whole something to keep in mind is what you need to remember is with any sort of cholestasis, it can also mess up potentially pancreatic enzymes. So whenever they give you lab values and they tell you that the lab values for the pancreatic enzymes are also elevated, you need to keep this in mind as a differential, right? If it's either an issue with the gallbladder obstruction or if it's a pancreatic issue caused by maybe alcoholism or something else, okay? And I'm going to cover those lab values with you guys shortly. Guess what? I told you guys this, HMG-CoA reductase activated by insulin. So tell me, guys, you guys know your week 1 and week 2 knowledge. Is it phosphorylated or dephosphorylated? Dephosphorylated. I love it. You guys are getting those, okay? Make sure you guys tie these concepts in. This is essential to know. Guess what? Insulin is going to predominate here. What's going to downregulate it? What's opposite of insulin? Statins would work, glucagon would work, are all going to downregulate the activity. Okay, awesome. Now, ammonia acid and urea cycle. This is one of the ones I'm going to tell you guys to know cold because it threw a lot of people off. Okay, just to start off with the basics, amino acids, right? Private Tim Hall. You guys need to know that very well. But now that you guys have covered a little bit of DM, or a lot of DM, you need to know your glucogenic versus your ketogenic, okay? So glucogenic is methionine, histidine, and valine. We met his Valentine, who is so sweet, right? So met his Valentine, right? Met his Val are all glucogenic. Whereas your ketogenic are typically your leucine and lysine, and they're only the pure ketogenic components. Obviously, there's glucogenic and ketogenic. You don't need to get nitty-gritty into those, but know these two also very well, right? His Lies Are Basic is one of my favorite kind of first aid mnemonics. It's a classic. It's lovely. Okay. Let's kind of get a fundamental principle out of the way. Nitrogenous waste in our body is bad because nitrogen can precipitate into a lot of free radicals, and also it's neurotoxic, right? It can go in and mess up. This is something I'm going to cover in NB a little bit more, but it is neurotoxic. So you have to get rid of your nitrogenous waste and your ammonia as quick as possible, right? So that's why your liver, as always, it does everything under the sun to help convert it into urea. Urea can then eventually pass into the kidneys, and in the kidneys with the glomerular filtration get passed out, and it can be nitrogenous waste input. When you guys get to further on, or you probably covered in term 1, creatinine, right? Uric acid and ammonia and all these things are lost in the urine. And that's something that we monitor as budding physicians. So the two things to keep in mind is that glutamine is going to be one of the primary carriers, right? Glutamine, amine sounds like a nitrogenous group, which it is. So guess what? Glutamine can convert via glutaminase enzyme into the nitrogenous waste that you're seeing here, and it can recycle the glutamate to eventually shuttle more of the nitrogenous waste through the circulation system. Remember, we can't just have free circulating nitrogen waste. It's bad, neurotoxic, like I said. Something to also keep in mind is that you can have cystinuria. Don't get it twisted with the homocystinuria in terms of stones precipitation. Cystine can be precipitated via the renal tubules into cystine stones. This is something you're going to cover later. You guys don't have to get too much into depth with this. Just know that cystine stones can exist. Okay, cystine, right? It's hexagonal, right? It's a buzzword. If you think hexagonal crystals, buzzword for cystine stones. Whereas gout, right? Those are the spindly ones. So if it has bifringens, it's gout, okay? It's urate, it's uric acid. Just keep those two concepts separated. Okay, let's talk about Hartnup disease. It's a transportation of tryptophan. It's a basic deficiency in it. So what it typically manifests as a niacin deficiency. So can you guys tell me what are the three, I guess, D's of the whole niacin deficiency? There you go. And the fourth one is the one that we want to avoid, which is death. Okay, 3 or 4. Obviously, you want to make sure you keep an eye on the patient's niacin levels. Guess what, guys? Niacin is implicated in a lot of things. Tender, loving care for Nancy, right? Niacin is one of the components that you need to keep in mind. So they can ask you a niacin deficiency question and lead it into an enzyme question. So just make sure you guys tie in those concepts. Okay, so how do we shuttle around all this nitrogenous waste? Alanine is one of the great ways. Guess what? You guys know what ALT is? You guys do know what ALT is because you guys have covered it since term 1. Alanine aminotransferase or alanine transaminase. ALT is one of the measuring values that we take for liver function enzymes. Okay, what it does is it takes alanine with combination of its cofactors, right? Paradoxal phosphate, which is vitamin B6, PLP. Essential to know that. Okay, make sure you know that ALT go with PLP. I like that because they kind of sound like a rhyme. ALT, ALP go together. Alanine to pyruvate, right, is essentially takes the nitrogen that's on alanine and throws it into alpha ketoglutarate and converting it into glutamate. The nice thing with glutamate is that it can hold on to this nitrogen and it will carry the nitrogen and eventually can take this and give this back into in the kidneys as nitrogenous waste and eventually as excretion of ammonia. Now, another thing that can be involved with this is aspartate, right? Asparagine, aspartate, and oxaloacetate are really important because asparagine is one of the very few enzymes, or sorry, amino acids that can go directly into your amino acid kind of loss of your nitrogenous waste. And I'll cover that in a little bit more, getting down this kind of rabbit hole, okay? I would know this cold. I would know this cold based off of, I think, give me 1 second. Asparaginase is important for the treatment of leukemia, right? Asparaginase reduces serum asparagine, which then starves the tumor because the tumors are very highly active and they're using up a lot of your proteins. And in that process, they create a lot of nitrogenous waste. So this is something that we can use to monitor any sort of tumor growth and progression. Remember, ammonia has a whole bunch of nitrogen that we can throw onto it. And the other thing we can do is recycle this back into aspartate. And this whole cyclic process can eventually lead to oxaloacetate, right? Which is oxaloacetate is really important because it's once again helps with taking apart your asparagine, right, into ammonia, and then taking the one extra nitrogen that's here in and throwing that into glutamate. So the essential things that carry it, that's N2 in terms of how many nitrogens that it can hold, okay? So asparagine can hold 2 nitrogens, whereas aspartate can only hold 1. So as you guys are going through this, remember, we have to balance the equation. So where does the first nitrogen being lost go to? It can go to ammonia, right? You can also put it into aspartate, and from aspartate, it can be shuttled over and over until you have sufficient levels of ammonia made, or you can go through the aspartate to oxaloacetate pathway leading to glutamate, okay? Remember, you guys covered AST. This whole pathway can be a little confusing, and I've linked a Ninja Nerd video at the tail end to go over it like a full picture. It's a little hard to do with just like slides, so just keep that in mind. Glutamate, this is covering the glutamate pathway. Glutamine can hold on to 2 nitrogens, right? So this is the whole cycle going through. Make sure you guys know the fixations and which ones can typically let the conversion from the brain to the kidneys to what happens at the liver, etc. Okay. Transport of nitrogen from the peripheral tissues. As always, ammonia is neurotoxic. That is important. You don't need to know how neurotoxic yet, and I'll show you guys that in a bit. Nitrogen formation in the liver, right? Alanine and other things play a huge role. And I'm going to show you guys this in a hot minute. What you need to know is that from glutamate, we do oxidative deamination by glutamate dehydrogenase. Guess what? Glutamate dehydrogenase, it's a dehydrogenase, so it needs a little bit of cofactors, which I cover in the previous kind of recording. Okay, here is the overview. Obviously, I really didn't like this picture, so I just told you guys that overall, what you need to know is that urea is not charged because it's a balanced out kind of charges. Keep that in mind. Urea can be excreted quite easily. That's why it's helpful. Any sort of charged particle can eventually be brought back in. Here is the whole kind of picture. I really like this because it walks you through the entire process, what happens at the muscle, at the liver level, and then what eventually happens at the circulatory system, and eventually in the release of any sort of kind of components. Obviously, you guys have learned that alanine plays a huge role in converting your whole pathway from alanine to pyruvate, which then can create gluconeogenesis, right, in order to increase blood glucose levels and eventually give it to the peripheral tissues. So go through this pathway, explain it out, and it helped me a lot. Okay, urea cycle. Now, this is where a good bulk of your questions are going to come from in terms of your amino acids and your urea cycle questions. What you need to know is that each step of this process has some kind of issue, right? Some kind of disorder, some kind of enzymatic deficiency. Now, the first thing that they like to ask is any sort of deficiency in CPS1, right? It's carbamyl phosphatase synthase 1. I'm not going to say it again. It's mitochondrially located, activated by NAG, and it's conversion of ammonia into carbamyl phosphate, and from carbamyl phosphate, you're going to go to via OTC, which is ornithine transcarbamylase, to citrulline, while you combine carbamyl phosphate with ornithine to create citrulline. Okay, I can go through this entire pathway and explain it out, but honestly, when I did this, I was just running through this whole pathway via questions. So I highly recommend that you guys go through this pathway by doing practice questions that are posted on Sakai. What you need to know is that citrulline, right? How they're going to ask questions for this is that if there's any sort of OTC deficiency, what you're going to see is basically a table showing you that citrulline is decreased, carbamyl phosphate is increased, and that's how they like to typically ask those questions. So that's why I'm telling you guys to know this entire pathway cold, because any sort of enzymatic deficiency, they're going to ask you which one's going to be elevated, which one's going to be decreased. Okay. Here it is. Here's the walkthrough. Hyperammonia type 1, that's a CPS1 deficiency. So that's happening right here. Hyperammonia type 2, this is the most common. If there's one that I want you guys to know cold, it is OTC deficiency. It's ornithine transcarbamylase deficiency, hyperammonia, increased orotic acid, right? Because remember, ornithine can't just hang out by itself. It gets converted into, orotic acid and excreted in the urine. So if there's any sort of OTC deficiency, you're going to see orotic aciduria. Okay, that's a very kind of buzzword level question. Citrulline deficiency, citrullemia, what happens is you have a deficiency of arachnosuccinate synthase deficiency, ASS, right? That is going to tell you what's going to be elevated, hyperammonia, right? Because you don't know what to do with all this nitrogenous waste, and increased levels of citrulline. That's how they like to ask these questions. I would know this table cold, okay? Here's the full picture. Once again, I wanted you guys to have a nice clean picture. I felt like everything was kind of cramped here. I would add in the disorders and I would go over this entire pathway. Once again, what would you use to treat for this? Any sort of butyrate or phenylacetate are potential ways that you could treat it, and benzoic acid helps with this too. Typically, it helps with the phenylacetate and the condensation of glutamines, and phenylacetylglutamine can eventually be excreted in the urine. This is an alternative pathway that you're upregulating with the treatment of phenylbutyrate and benzoic acid. Okay, long story short, with ammonia neurotoxicity, it gets deposited in the brain. It deals with kind of imbalance of electrolytes and other components. Don't need to spend the entire time learning this because they're going to cover it in NB. What you do need to know is that hyperammonia is bad, right? It balances and changes the neurochemistry and the neurotransmitters that are eventually released, because glutamate can be converted into, guess what, other neurotransmitters, and that can change the way your body reacts to all these neurotransmitters. Okay, biochemical defects in PKU. Now, PKU is one of those things that can be diagnosed early and that they actually test for in children first thing right off the bat. I would always tell you guys to learn this very well because PKU has been taught to you guys since term 1, and they like to ask classic kind of questions with this because it's Dr. Sobering's level questions. What you need to know is that what you're deficient in is phenylalanine hydroxylase, okay? What happens is you take phenylalanine and you convert it into tyrosine, right? Tyrosine is super important because what you guys remember is that tyrosine can be then sufficiently created into melanin and then eventually other essential amino acids, and then, your whole kind of creation of certain hormones, as well as metabolic products. Phenylketonuria, very common, right? Autosomal recessive PKU. So this is classic PKU. There's also PKU type 2. I'm going to go over that. And as always, they check in infants twice because remember, mom's blood is still circulating around the baby. So they have to check twice after the baby creates its own set of blood and the liver functions kind of take over. Okay. As always, limit phenylalanine and you should be good. Typically, they can have normal lifestyle. Avoid phenylalanine. Saproprietine, which is a form of BH4, is really kind of a saving grace, but it can only work in mild to moderate cases, and it's not like a fail-safe kind of cure. You still have to make sure that they don't take PKU, or sorry, they don't take phenylalanine in their diet for PKU. Okay. Low phenylalanine, maternal PKU. The thing is, the baby could be completely normal. Here's the thing. The baby could be completely normal in maternal PKU syndrome, but due to the levels of low phenylalanine before conception, it can be bad. It can lead to microcephaly because, any sort of amino acid essentials are always going to have neurological issues. Lack of developmental milestones, which is something you're going to cover in NB, and congenital heart defects. You guys will cover that in depth. Well, you guys technically covered it before. Alkaptonuria. Now, this one, they're going to ask you in terms of enzymes. I wouldn't need to know the entire pathway for this. I'm telling you guys, all you need to know is that associate alkaptonuria with homogenistic acid oxidase deficiency, okay? What you need to know is that it's going to present with ochronosis and brown colored urine. Essential buzzwords. I think there might be one more that helps you remember it. But ochronosis, if they tell you that their connective tissues, especially in the spinal cord or the spinal column, is black, or their urine is black on standing, it's telling you that there is any sort of alkaptonuria. Guess what's deficient? Homogenistic oxidase deficiency. Okay. Leads to severe arthritis later in life, but it's not necessarily one-to-one. Tyrosinemia, this is due to the fact that you have a buildup of formal acetoacetate Remember, formyl acetoacetate is one of the compounds. Whenever you're kind of thinking of this is like cabbage smelling urine. So whenever you're thinking of buzzwords for these, I learned these basically on buzzwords alone. So I do apologize if I throw anyone off. What's deficient is in tyrosine type 1, if they ask you, is formyl acetoacetate hydroxylase. Okay, there's also tyrosine type 2, and that's tyrosine aminotransferase. That one you don't need to know too much in depth, but if they tell you any sort of cabbage smelling urine, you guys know right away. Tyrosinemia, this is the enzyme that's implicated. Alkaptonuria, any sort of black colored connective tissue or black urine, homogenistic oxidase deficiency. Phenylalanine, you guys have heard PKU since like term 1. I'm gonna assume you guys know that very well. Okay, AMSA deficiency. Okay, this is the branched chain issue. What you need to know is that any sort of branched chain alpha ketoglutarate acid is basically implicated here. You guys know your branched chains by now, like leucine or isoleucine, leucine, there's a couple of other ones. But what you need to know is that MSUD is a deficiency of this, right? The branched chain alpha keto acid dehydrogenase, okay? Once again, this can lead to 2 different kind of presentations. It can present with ketosis or maple syrup odor in the urine. Obviously, this is much better than like, I don't know, smelling cabbage in the urine or anything like that. So it's very weird, but it's a great correlatory component, okay? Once again, ketosis and maple syrup urine. All righty. Treatment, what are you gonna do? Make sure that you have, consider the importance of vitamin B1, right? Thiamine. What you need to know is that TLC for Nancy, right? Guess what? It comes back with your dehydrogenases. Important to know that always. Okay, this one was a little odd because I realized that this was how odd chain fatty acids get broken down. Because remember, our body never just gets like even chain. Because remember when we were covering it in the last kind of review, we were just talking about palmitic acid CoA, right? Palmityl CoA. Here we have odd chain, right? We have 3 carbon groups. We have like 5 carbon groups. We don't know what to do with it, but we can eventually convert them into products that can be brought into the TCA cycle, or they can be fed into other pathways. But obviously methylmalonyl CoA is going to be super important because what happens to propanyl CoA, which is a 3-chain carbon group, it needs to be converted into methylmalonyl CoA. And if you have a deficiency of methylmalonyl CoA mutase, right, you're not going to be able to create succinyl CoA. And guess what? Succinyl CoA can enter the TCA cycle because succinyl CoA is something you create, right? It's a substrate that eventually can make the rest of the pathway continue along. So guess what's going to happen if you have methylmalonyl CoA mutase deficiency? You're going to have methylmalonic acidemia and aciduria. Very simple, nothing too crazy with that. It's pretty bad because remember, neurologically, you're trying to use any of your fatty acids because remember, your fatty acids are implicated in your ketone pathway as well. So it can have neurological presentations with like seizures and encephalopathy. And what you need to know is that B12 is implicated here. So biotin and B12 are typically going to be supplemented, but B12 is the important one. If they give you both, right? If they give you biotin or vitamin B12, go with B12. B12 is a very important thing. I'm going to cover B12 a little bit more in depth because of a couple of questions we got regarding it. Biochemical defects in homocystinuria, okay? This is how we deal with taking cysteine, right? We take methionine and convert it to homocysteine, but then eventually we take the homocysteine via this minor pathway and convert it into cysteine, and cysteine is very useful too. What happens is there's a deficiency of cystathione beta synthase, right? Deficiency. That's homocystinuria diagnosis. What happens is it's going to mess up their connective tissue, so they might be more prone to any sort of arthritis and other kind of components. They might have degenerative cartilage diseases. High levels of homocysteine in the plasma and the urine. Very simple. If you guys remember that, you should be good. What you often see with this is that they can kind of present like with folks with Marfan's. So don't get this one and Marfan's twisted. They can be very long, tall, etc., whatever. But the way I remember it is that the dislocation of their lens is actually sublux down. So, right, their lens pops downwards, whereas with Marfan's, it pops up. Okay, so it subluxes up with Marfan's. So just something to keep in mind. As always, some patients might respond to oral B6. It's not shown to fully help. Okay, 1 carbon metabolism, and I think there's a break coming up in a short bit so that you guys can hopefully get some water and refocus. PKU, sometimes called malignant PKU. This is kind of bad because what happens is dihydrobiopterin synthesis or dihydrobiopterin reductase gets messed up. Whether you're going from BH2 to BH4, sorry for the plane in the background, what happens is you're going to have severe central nervous issues, right? Neurotransmitters get messed up, serotonin and catecholamines. Because remember, you need tetrabiopterin when you're dealing with any sort of the cofactors for making these serotonin and catecholamines, right? Such as your dopamine, norepinephrine, epinephrine. And I'll show you guys the entire pathway. You can't really treat it because remember, these stuff can't pass through your blood-brain barrier. So it's important to you guys remember that. So what are you not making when you're not converting tetrabiopterin to the active form? What you need to remember is that tyrosine, right? Tyrosine can be eventually converted into L-DOPA and then your norepi and epi, right? So that pathway, what happens is you're going to have decreased melanin. People might be albinism. They might have albinism. There you go. And also you need to remember that tyrosine is an essential amino acid. So that's going to be potentially elevated. Phenylalanine gets elevated too. Phenylpyruvic acid is going to be elevated and it's going to have mousy urine. So PKU type 2, mousy urine, keep that in mind. Okay, what are the pathways implicated and what steps? Phenylalanine hydroxylase gets messed up because phenylalanine to tyrosine, right? You need tetrabiopterin, right? Tyrosine hydroxylase, tyrosine to DOPA also needs it. You also need it for tryptophan hydroxylase, which converts tryptophan to 5-hydroxytryptophan. And remember, that's like the one more step before you create serotonin. And there it is, right? 5-hydroxytryptophan, right? You need, right, eventually to create your serotonin. Tryptamine, right? And that's how you have serotonin, right? So implicated ones. So right here, right here, and that's the essential one to keep in mind, and you should be good. We're also going to talk about SAM in a bit so that you guys know. Moving right along. Okay, yes. So as always, 1 carbon donation, you need, cobalamin, right? And kind of a combination treatment of folate and vitamin B12, and that typically helps with some of this. But as always, it's not a good kind of diagnosis. Fate of homocysteine, keep in mind, homocysteine is one of the minor side pathways. It's the way that we can take homocysteine and convert it into methionine, which then can get a methyl group to create S-adenosyl methionine SAM, which holds on to a methyl group that can eventually be passed on to create norepi. From norepi to epi. So it's one of the last steps. So they might have high levels of norepi, but they might have low levels of epinephrine. Okay. Significance, metabolism of homocysteine requires folate, vitamin B12, cobalamin, and vitamin B6. Okay. Folate deficiency, I'm going to keep it very simple with you guys. Whenever you think of folate or B12 deficiency, it's megaloblastic anemia, and there's a nice table because B12 is a big number, megaloblastic, right? 12 is a bigger number than 6. B6 is going to be typically presents with microcytic anemia. Changes in folate deficiency, as always, what you guys need to remember is folate is essential for pregnancy, right? Mothers will actually start on a folate before they even attempt to get pregnant because neural kind of development takes place well before you can get a positive diagnosis for a pregnancy. So it's important to start your potential mothers on folate. Decreases in hemoglobin concentration. macrocytic megaloblastic anemia, right? Macro is the buzzword for this case, okay? And if they ask you about WBCs that are like polysegmented, that's also a potential buzz, but most time, whenever you're thinking of megaloblastic or macrocytic, it's the thing to keep in mind. Okay, FIGLU. I like this one because it sounds funny, okay? Histidine gets converted to FIGLU. It's a multi-step process, but what you essentially do is take FIGLU and convert it into glutamate, right? Glutamate is one of the carriers of your nitrogenous wastes. So it's important that you create this minor kind of pathway to keep sure it functions properly. But what you have a deficiency of is either folate, so that you can't take this formamic glutamate and convert it into glutamate. So if there's a folate deficiency, it's going to present with increased levels of FIGLU excreted in the urine, and you should be solid if you know that fact. B12, I told you guys, know it cold. Failure to absorb B12 can be caused by multiple things. As always, a typical presentation in terms of lab value is going to be macrocytic megaloblastic anemia, neurological issues, tingling stuff. Most often, what they're going to ask you in terms of DM material is loss of the parietal cells. Guess what? Intrinsic factors at the distal end of the ileum, everything gets absorbed. Okay. You can also have diseases of the ileum, such as tuberculosis or Crohn's disease. You're going to cover those a little bit later, more in depth. Okay, folate deficiency. You're going to have both cases, right? Macrocytic megaloblastic versus a deficiency of B12 as well. They're going to be the same thing. But the thing that will distinguish it from a folate to a B12 deficiency is the neurological manifestation and the increased homocysteine and methylmalonate levels, right? That is the diagnostic parameter that you're going to use, okay? As compared to folate, is just going to have, like, you know, typically your changes to your blood composition, right? Increased homocysteine, that's it. Most of the time, methylmalonate is the one that you need to keep an eye on. Okay, we're going to take a quick 5-minute break so I can chug some water. But I'm going to take a pause on the recording. All right, guys, welcome back. Let's tackle a couple of the other pathways that I found were high yield. Heme metabolism is really, 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 really important. Okay, they're going to ask you guys a plethora of questions with this. It can be quite intimidating to look at right off the bat because you need to know each step of the pathway as well as where everything is happening, whether it's in the cytoplasm or if it's in the mitochondria. So spend some time going over this pathway. Don't sleep on this because each step of the way there's some kind of disorder or deficiency. Okay. All right, a trot slide just for good measure. So this is happening in the mitochondria. First off, okay, succinyl-CoA, guess what? That's a product of your TCA cycle, right? Think of it that way. Glycine combined together to create gamma aminovalinic acid. I cannot pronounce these. Please excuse me. But what you need to remember is that ALA synthase is super involved in this pathway. If anything, whenever they ask you about rate limiting steps for this, it's going to be this, okay? Whenever there's a deficiency or issue with this, it's going to be an X-linked sideroblastic anemia. What else messes with this, guys? Potentially your, what's a downregulator? You can also be a downregulating via hemin, right? Hemin is something that you create early on right here, right? Later on in the cycle that can have negative kind of inhibitory factor, as well as glucose, right? Glucose will also inhibit ALA synthase, okay? ALA synthase 1, awesome. Rate limiting step. What's the cofactor that you guys need for this? Put it in the chat for ALA synthase. B6, exactly. Nicely done. PLP, B6 works fantastic. So make sure you guys know your cofactors or vitamins involved in this. Let's look at microcytic anemia. What did I tell you guys? Microcytic anemia is a deficiency of B6. You guys know it very well because remember, this pathway is essentially dealing with how heme, right, which is one of the components of the path, which is one of the ways you can create hemoglobin, which is eventually going to make up the primary components of your oxygen carrying capacity of your RBCs. So this is why the entire picture needs to be brought together. because when B6 deficiencies are there, it's going to lead to microcytic anemia. B6, microcytic anemia, B12, macrocytic megaloblastic anemia, right? Keep those together as like your go-to answers whenever you see those vitamin level questions. Lead poisoning can also mess with this. Remember, there are a couple of places that lead, a heavy metal kind of chelating agent, takes up a lot of these kind of components. It interacts with the zinc that's freely floating around and allows for ALA synthase to not work properly, okay? What else is going to be accumulated, right? ALA and a small amount of protoporphyrin accumulates in the blood and urine. Okay, this one. Okay, know that this is going to be elevated and that you're going to have decreased levels of porphobilinogen, levels decreased. Remember, zinc is inhibited by lead. Okay. What else? We have another thing that's being inhibited, ferrochelatase, right? Ferrochelatase is also inhibited by lead, right? Zinc is basically sucked up by lead, and it doesn't allow for ferrochelatase to make the final step of the heme pathway. Most of the time, if they ask you this, it's going to be in terms of this as compared to this, because this is a later stage issue. You need the whole pathway to kind of not happen. Okay, lead poisoning, little kid consumes paint chips and all, so that's a good one. Important to know that one. Make sure you guys remember that general key. Okay, what else? HMB synthase deficiency. This is the way they ask these is actually a little bit difficult, because what you need to remember is a little bit what happens with the urine in terms of, does it change color on standing? It all depends on the exposure of light to these structured heme, like early heme components, because when they are in a cyclic nature, they can then be converted into a darker color as compared to when they're early on, when they're not able to. So what's going to be elevated? Porphobilinogen is going to be elevated, as well as your ALA, alpha aminobutyric acid, and that's going to be elevated too. So these values are good to memorize, to keep in the back of your head. AIP onset of AIP, typically specific drugs, heme synthesis, right? Infection, alcohol abuse, any sort of these can typically cause this. Remember, barbiturates can lead to toxic ALA levels, right? Not good. In patients, ALA is very similar to GABA. And remember, GABA is basically a down regulatory system. So it's going to suppress the central nervous system. And if you have high levels of GABA, you're going to cause death. Okay, not good. Hydroxymethylbilin is very important in terms of erythroid uroporphyrinogen type 3 synthase deficiency. Know that this is going to be elevated, because remember, everything else here is happening at the mitochondrial level, so it can't really cross over and mess around with the porphobilinogen and ALA. So it's going to be typically hydroxymethylbilin that's elevated. Okay, there's another name for it, uroporphyrinogen type 1. They have multiple names. Always keep this in mind. Deficiency of erythroid, uroporphyrinogen 3 synthase can lead to what you're seeing here, congenital erythropoietic porphyria. This is quite difficult. It's challenging to memorize. I'm going to tell you guys to go through this pathway, but know it cold. Clinical features, what you need to know, buzzwords is teeth reddish brown, and any sort of like werewolf-like presentations, hair, facial, arms, and all those other things. So red urine and positive photosensitivity. So keep this in mind. You want to give these kids like less sunlight, but you would also want to double check their your urine kind of composition. Okay. CEP patients, right, have severe pain when the skin comes in contact with UV light, because what happens is the porphyrin isn't like properly in its actual heme-like composition, so it reacts and causes severe kind of blisters and open wounds. So it's ROSs, which is, you know, radical oxygen species formation. It's not good. It's not a fun time for these kids, and it's quite difficult to kind of manage. Okay, this is hepatic porphyria. This one is a little difficult because what happens is uroporphyrinogen decarboxylase deficiency And what you need to know with this is your porphyrogen type 3 is elevated, okay? Porphyria cutaneous tarda, this one is not too bad because it's common photosensitivity with cutaneous lesions caused by this accumulation of uroporphyrogen type 3. Heme synthesis, right, gets upregulated because you have a whole bunch of uroporphyrogen and that's telling you like, hey, move this along, but it can't, okay? Urine is red and can be pink in fluorescent light. That's the buzzwords for those. Skin photosensitivity, know these very well. Congenital erythropoietin porphyria, CP, porphyria cutaneous tarda, know that, as well as what you see in terms of photosensitivity for each patient, okay? There's gonna be severe photosensitivity here, and here you won't see that. Porphyria cutaneous tarda is typically not too bad because you can typically only just see blood, tissue, skin, and urine level issues at hand. Here's the full pathway and what each disorder can lead to. And I wanted to highlight a couple of ones, right? ALA synthase deficiency, ALA dehydratase, right? Lead poisoning, porphyrogen deaminase, that's the acute intermittent porphyria. And then you can have your porphyria cutaneous tarda, as well as your ferrochelatase levels. So if you know these typically cold, then you should be good for the exam. Okay, I would also spend some time learning the cytosolic and mitochondrial components because often they asked us exactly where this was happening, or they gave us this kind of hint in the stem, and it allowed you to eliminate a couple of the enzymes that you either could remember or not remember, and you could just go through a process of elimination with that. Okay, here is the whole kind of modification pathway. Because remember, we need to make a heme group, right, that's stabilized with iron. So that's why the cyclic nature allows for the more cyclicalized, or the more cyclic in nature it is, it's going to have a greater chance of having free radical oxygen species interaction, because you don't want iron kind of to be messed around with oxygen in general. Okay, bilirubin formation, this is important. Okay, guys, stick with me with this one. Any sort of, like, let's say you have sickle cell anemia, right? You're going to have increased RBC turnover, right? Whenever you have RBC breakdown, you're going to have increased levels of unconjugated bilirubin, right? This is where we get into the discussion of prehepatic, hepatic, or post-hepatic issues with heme breakdown and conjugation. Bilirubin is the key thing implicated in this, right? Let's say when you're going through this pathway, right, you have increased hemolysis, right? Bilirubin gets elevated. Your liver is still working fine, right? It's doing a good job of taking bilirubin and converting it into conjugated bilirubin and eventually letting it pass into the circulatory system. Sorry, not circulatory system, going down the common bile duct and eventually into the intestines. From there, it gets converted into stercobilin and urobilinogen, which gives the color of urine and feces, right? That's where I'm getting to this, where I want you guys to know prehepatic, hepatic jaundice, and post-hepatic very well, because it's definitionally given to you by having what's happening at the body with these definitions. So prehepatic, right? It's typically happening increased RBC turnover, right? So RBCs, about 120 days of life. If it has increased, such as with sickle cell, alpha and beta thalassemia, and a whole bunch of other things can potentially lead to what you're seeing with increased RBC death. Hepatic jaundice, you're having some kind of, let's say, acute or maybe progressive, like chronic kind of states with like alcohol consumption, etc. So that's going to lead to a decreased excretion of bilirubin because you have some level of hepatic level trauma. Post-hepatic is just typically a blockage, right? Whether it's at the pancreatic level or if it's at the gallstone level, it can have these effects too. Okay, like I said, 120 days. What you need to know that at the splenic level, right, everything in terms of RBC breakdown is happening at the spleen. Okay. Remember, sinusoidal capillaries allow for the capture of all these messed up RBCs or damaged RBCs. Heme has to be taken, globulin, amino acid, right? They all get split up. Globulin can be recycled. Heme has to be gotten rid of, right? So heme from like myoglobin and other things have to be broken apart and get converted into bilirubin. So I'm actually going to tell you guys this in a little bit of why we need to know bilirubin so well, because it can also be implicated in any sort of tissue level trauma. I'll show you guys that in a bit. Increase RBC, right? I showed you guys increase bilirubin formation, increase unconjugated bilirubin, right? Because this is all albumin bound. This is a normal process, just happening too much of it. Okay. Your liver can't keep up with the amount of RBC turnover that's happening. So what's going to happen? Increase bilirubin uptake, increase excretion, increase formation of urobilinogen. And so you're going to have increased urobilin and stercobilin. All right, so laboratory findings. I swear to you guys, you have to know these. They have questions on every exam that I've talked to for the past 2 terms have had questions on this. Critical, critical, critical. Laboratory findings for prehepatic, guess what? Serum total bilirubin is elevated, but your serum conjugated bilirubin is normal because your hepatic, your liver is working just fine. So the unconjugated levels go up. So remember, total bilirubin is a combination of bilirubin conjugated plus unconjugated. So obviously, if unconjugated is super high, total bilirubin is also going to be super high. Urine bilirubin is going to be absent because, your unconjugated can't essentially just, dissociate and show up in because it hasn't gone through the gastrointestinal system. Remember, through the small intestines and brought back in. It's not soluble, so it just gets passed in the feces. So urobilinogen gets elevated in that component. Okay. Hepatocellular jaundice. Typically, the most common cause is alcohol damage, right? What are you going to have in terms of lab values? Your AST to ALT ratio, highly elevated. So think about your 2-to-1 ratio. So that's kind of a hint at what you might likely see. Sclera ictus is a buzzword. Whenever you see any sort of yellowing of the sclera, you're going to cover the eyes so well in a hot minute. In NB, indirect, unconjugated, and direct is also going to be elevated because what happens, your liver just can't keep up. Okay. Your RBCs are dying, right? Formation of bilirubin is bound to albumin from the splenic components to the liver component. The increased unconjugated bilirubin in circulation. So you're going to have decreased uptake and conjugation of bilirubin by the liver, and eventually you're going to have increased conjugation of bilirubin in the circulation due to regurgitation because you're having tissue level damage. So your hepatocytes can't really bring back these components, and the loss of bilirubin in the urine. So everything else outside of this gets decreased, right? Decreased excretion of urobilin, decreased excretion of stercobilin in the feces. So it makes sense. Laboratory findings, basically everything is elevated, right? This is bad. This is why we don't like to have hepatic level trauma. This is why they don't encourage, binge drinking or high levels of chronic alcoholism. Elevated values, right? Serum ALT and AST. What do you guys use to cross compare your ALT, AST values to in terms of, put it in the chat in terms of what you would see? Well, what other serum levels would you be monitoring? Yep, ALP is important, GGT, okay? That's important. You have to cross compare those values so that you guys don't pick the wrong answer in terms of a hepatic level trauma versus a post-hepatic, typically an obstructive level thing. ALP and GGT are most often seen at the endothelium that's lining the common bile ducts, and that's why those are elevated. Obviously, GGT is preferred. ALP is actually found also in the bone, so just something to keep in mind in terms of differentials. Okay. Post-hepatic, obstructive, right? Remember, this is straight up just like a blockage. What are you going to have? Pale colored stool because steatorrhea, right? You're not absorbing fats, so the fats aren't going away. The patient is losing a whole bunch of weight. There's no kind of fat soluble vitamin intake, so there's going to be a lot of neurological components as well, and there's a lot of immunological suppression as well. Okay. You guys know this, it's a blockage. You're still having increased levels of conjugated bilirubin because your liver is working just fine. You just can't seem to put out all of this wonderful conjugated bilirubin into the intestines because it's blocked at the common hepatic duct, right? Once you have that information down, everything else in this pathway makes sense. Physiological jaundice. You know what? Babies are born, especially premature babies. And this is a very common thing that you might see in the intensive care unit with pediatric patients. They just have low levels of UDP, glucuronol transferase. Oof, I cannot pronounce words today. It is basically they have increased RBC destruction, right? Because their liver is overworking, trying to like make sure that they're producing sufficient levels of other proteins, and they really can detoxify essentially the increased bilirubin that's being brought into them. So they might have a little bit of jaundice, and the reason is that what type of thing you would see elevated is unconjugated. Their liver isn't fully ready to deal with the high levels of bilirubin that's coming in. So why is jaundice bad? Because unconjugated bilirubin can go across the blood-brain barrier, because remember, it is permeable through any sort of lipid-like structure. It can damage the basal ganglia, which is something you're going to cover in NB, but just know basal ganglia and kernicterus is the buzzword for jaundiced babies. Okay, there's a lot of neurological implication. Now, inherited unconjugated bilirubinemia, what you need to know are these three: Crigler-Najjar syndrome 1 and 2, and Gilbert syndrome. Okay, if you know these three cold, you should be fine for the exam, because whenever we got questions on this, it was really regarding Crigler-Najjar, Gilbert's, or type 1 and type 2. Okay, now which one is the worst, guys? Tell me in the chat, which one's the worst? 1, right? There's a reason why it's number 1. It's the most severe. They basically have absolutely none of the essential components of the UGT, right? They have decreased UDP glucuronol transfer, or sorry, they have no UDP, so they have no glucuronol transfer enzyme. So they don't respond to any sort of drug that you throw at them. They don't respond to phenobarbital. So I would also know this as a tool, that the physician might give them phenobarbital and it's not going to do anything. And usually it's fatal if not treated due to kernicterus. You might have to do some kind of corporeal filtering of any sort of high levels of bilirubin just to make sure that these babies survive. Inherited unconjugated bilirubin, right? This is the type 2 area syndrome. I wouldn't spend too much time going over this one because you guys can identify it very quickly. It's lower activity. It's about 10 to 15. Most of the time they'll say 15% bilirubin, glucuronol, and transferase activity. It's not as bad, but they will be jaundiced. So what would you like to typically do with these babies? You would still like to potentially put them under fluorescent lights, and you're going to give them phenobarbital. Okay, very important to know that. Inherited unconjugated bilirubinemia, especially with Gilbert syndrome, is very important. It's typically a mild jaundice following illness or stress or starvation. Hopefully these babies are okay, but it just decreased activity due to like what you would typically see. Let me make sure I get my, oh no, Gilbert's is important. I'll talk about Dubin-Johnson in a minute. So Gilbert syndrome, I would know cold, especially mild increase in unconjugated bilirubin. Okay, so this is the sequence. I would know these very well. I would need to know, especially know that CJ1, Crigler-Najjar type 1 is the worst. Type 2 is okay. Gilbert is decent, right? It's just a transient kind of change. Okay. Age is often the buzzword that you would use to diagnose these patients. You know, the baby's looks severely high levels of unconjugated, then it's telling you Crigler-Najjar type 1, and it has hardly any activity of UDP or glucuronol transferase. Okay, I would also need to know what I want you guys to also memorize Dubin-Johnson syndrome. Dubin-Johnson syndrome, you're going to have high levels of unconjugated and conjugated bilirubin in their serum. What essentially happens is a defect in the ABC transporter. ABC transporter is the last step that you essentially use to bring out the conjugated bilirubin that's happening at the liver into the ducts, right? Into the common hepatic duct, et cetera, and eventually into the intestines. So if ABC is affected, you're going to see elevated levels of exactly ABC Dubin. Important to know. There you go. I thought, for some reason, I thought I didn't put this in, but Fantastic. It's conjugated direct bilirubin that's elevated. I would also spend time learning direct versus indirect because it's just a synonymous term for conjugated versus unconjugated. Okay, this is adults, right? As well as adolescents, ABC transporter implicated. Liver enzymes are normal. Know that very well. You would see elevation in both. Okay. Okay, guys, my favorite topic of the day, AST to ALT ratio, 2-to-1. A shot of tequila is how I remember it, okay? An ALT ratio, somewhat similar to kind of consider, is telling you that you have some kind of damage, either via like viral hepatitis or maybe something like autoimmune hepatitis. That's something you're gonna cover later on, but just know that ALT is associated with that. Now, ALP, alkaline phosphatase, is something to keep in mind. It's typically a bile obstructive kind of component. It can also be implicated in bone diseases. Alkaline phosphatase it helps you take the calcium and the phosphate and helps mineralize it to a sufficient degree that you can have bone deposition. That's a minor thing, but most of the time, if you see ALP and a GGT combined, you'd start thinking your biliary tree is obstructed somewhere along the line because the endothelium in that area produces ALP and GGT. If they tell you AST and GGT are elevated, guess what? The patient's been chugging alcohol, okay? Bilirubin, albumin, and prothrombin and platelets are also measured typically in parallel just to make sure that these patients' livers are still functioning or if there's some kind of biliary obstruction, okay? Keep that in mind. Physical examination, buzzwords for this: jaundice, abdominal pain, fever, any sort of chronic cirrhosis, right? Is spider angiomas are a buzzword for that. Gynecomastia. This is why you can also have central fat deposition because remember, any sort of chronic drinking can lead to central weight gain. So complications of liver disease, right? You can typically cause encephalopathies because remember, a lot of the proteins and stuff that you make eventually help deal with a lot of absorption in the brain. And, you'll learn Wernicke-Korsakoff till death in NB. Okay, GI bleeding, varices, coagulation disorders because platelet factors and other things are produced at the liver level. Okay, you guys know this, acute liver disease, ALT, AST ratio. It's typically for these is just 2-to-1, right? Long-standing chronic alcohol, AST to ALT. Know that solid, you're going to be fine. Gamma, right? Glutamyl transferase, GGT, and then ALP GGT, right? Typically telling you it's extrahepatic cholestasis, very high levels, and then intrahepatic cholestasis. Okay, guys, you guys are very smart on this material. What are the veins that are implicated in ascites? Throw it in the chat. What components? Superficial epigastric. Oh, that's caput medusa. Superficial gastric. No, I'm asking you guys about ascites. It's superficial gastric. It's not superficial epigastric, okay? It's superficial gastric. That's the important differentiating factor to know with ascites. Another thing to know is that it's going to be decreased levels of albumin. So they're going to have increased hydrostatic pressure, and it's a long-standing presentation with any sort of liver diseases, okay? Now, any sort of hepatitis, right, whether it's acute or maybe viral, it can be presented with your beta-gamma bridge. If you guys remember back to term 1, your beta-gamma bridge was essentially telling you that your immune system was hyperactive. And like any good liver, it can only do one job and one job only very well. So what it has to do is compromise in the levels of albumin that it's working with or it's producing. So you're going to have decreased levels of albumin and increased levels of your beta gamma bridges, which is your immunoglobulins, which you'll cover in term 3. So don't even trip, you just know beta gamma bridges very well. Ammonia, okay, I told you guys this to know the whole urea cycle very well. What you need to know is hepatic encephalopathy, altered consciousness, it can lead to coma, right? Because nitrogen is essentially can be converted into bad neurotransmitters that can suppress the central nervous system. Any sort of pancreatic level issues, it's going to present with elevated serum amylase and lipases. Know that very well, okay? All right, I should have actually put a break right here so that you guys could have all grabbed your drinks and then should have to the review. Okay, xenobiotic, okay? Xenobiotic, all it's telling you is that it's a potential drug that is metabolized by the P450 system. P450 is a whole family of different enzymes, right? They're all different isozymes. It's helping to deal with a lot of different drug interactions. But for now, you don't need to know all of those. All you need to know is two specific ones, CYP3A and CYP2E1, okay? Specifically for this, I would want you guys to know your ethanol, CYP2E1, because it upregulates the activity of that. Obviously, you guys can spend time going over this, inducers versus inhibitors. Fun fact, if you have grape juice right before you take a shot of tequila, it will last longer, but just don't take acetaminophen after that, okay? I'm just kidding. Don't do that combination. It's very bad. I'll explain why. Degradation of acetaminophen is normal, right? Normally, we go through either the acetaminophen glucuronate, which is we add a glucate. You add a glycated group to the acetaminophen. Geez, I can't pronounce words or let form normal sentences. Acetaminophen can also be sulfated and can be eventually passed on into the urine. What you need to know is that a minor pathway is CYP. It's primarily regulated by CYP2E1, and that converts acetaminophen to NAPQ1. Okay. Now, that is pretty much a toxic metabolite. It's very low. There's like 1 to 2% that's created. It's hardly anything. But when you have alcohol intake with acetaminophen, alcohol is going to upregulate the activity of CYP2E1, and then you're going to have too much of this, NAPQI, right? What is the treatment for this? It's N-acetylcysteine. Same thing with acetaminophen over toxicity, right? This is something we learned in FTCM in term 4. You need N-acetylcysteine for any sort of acetaminophen poisoning too, because you have too much of these pretty toxic metabolite, and that can lead to a lot of downstream effects. What happens is that you typically would want to convert it into a less active form or a toxic form and eventually let it excrete. So what do you need to know about alcohol? Alcohol has one of the very simplest biochemical pathways. There's only essentially two things you need to know. You need to know alcohol dehydrogenase, and you need to know your acetaldehyde dehydrogenase. If you know that, you have pretty much a good chunk of the pathway down, okay? Ethanol primarily works around the alcohol dehydrogenase to the acetaldehyde conversion, and from the acetaldehyde, it gets converted into the primary pathways through the mitochondria into acetate, right? And acetate can eventually be released in the urine. But if you have high levels of it, it can actually use a cytosolic pathway of acetaldehyde dehydrogenase 1, okay? So keep this in mind. This is a little confusing for a lot of folks. It's dehydrogenase 2 versus dehydrogenase 1. So 1 is in high doses. When you're so in one with the alcohol, it's DH1. Okay, I love that. Catalase. Important to know is that alcohol can actually be metabolized a little bit by the peroxisome. You don't need to know too much about it. I am going to make sure you guys run through this pathway quickly, right? What you need to know is that whenever you drink, there's high levels of NADH, right? That's generated. What it's telling your body is, I'm not really starving, so let's store as much of the stuff that we can. Remember, NADH is implicated in upregulating a lot of your fatty acid synthesis pathways, which is what I'm trying to show you guys here in terms of big picture. This is why you have central fat deposition with alcohol consumption, especially chronic long-term consumption. Okay, what happens is acetaldehyde gets converted from ethanol to acetaldehyde. From there, you go to exactly beer belly. Acetate, right? And acetate can then be subsequently converted into acetyl-CoA. And guess what? You guys know your acetyl-CoA. It's one of the essential pathway central points that can either lead to ketones, right? And fatty acid synthesis, right? Why? Patients with long-term alcoholic consumption are actually slightly ketoacidotic, right? Slightly. They can actually go into full-fledged ketoacidosis later on. if it gets severe enough, but ketones are implicated with long-term alcohol consumption. A little way I remember disulfiram, it helps, it's disgusting to drink alcohol when taking disulfiram because it takes away a lot of the positive effects that we associate with with alcohol, right? Acetaldehyde, right? To acetate conversion is done by acetaldehyde dehydrogenase, typically in the mitochondrial component. Disulfiram inhibits this. So it worsens a lot of the things, but if they binge drink, it can be pretty bad. Cholesterol synthesis can also be upregulated too. Yes. Okay. Yes, honestly, this one isn't as high yield. All you need to know is that microsomal ethanol oxidase system is mainly active in high ethanol levels. It's typically cytoplasmic. You don't need to know about in terms of mitochondrial. The mitochondrial is the regular pathway. Cytosolic is higher levels. Okay. Now, toxicity. We kind of covered this already, so you guys just need to know that it turns it into acetate and acetyl-CoA eventually gets made. So you have that down. Okay, so to all of my Asian friends out there who have this deficiency, it's called Asian flush syndrome. It essentially, you have toxic levels of acetaldehyde. Now, let me tell you how bad alcohol is on my little pulpit today. Acetaldehyde is essentially an analog to formaldehyde. And you know what formaldehyde is? Back in the day, they used to preserve bodies with it. So that's how toxic acetaldehyde is. So we have to quickly convert it into acetoacetate and eventually into acetyl-CoA. Otherwise, you get really bad levels of presentation that you're seeing here. A lot of folks have this ALDH2 issue, right? The patients essentially don't have this acetaldehyde dehydrogenase converting enzyme. So they have this flushing, elevated heart rate because acetaldehyde has kind of positive sympathomimetic effects in your body. So it can also cause central nervous issues because remember, you're not converting acetaldehyde, and acetaldehyde can cross the blood-brain barrier and mess up a lot of your there's a vomiting center you guys are going to cover in NB. I'm not going to tell you guys now, but like that's fun things to keep in mind. So here it tells you the entire mechanism. I already showed you guys this once. This is more high yield. This is what I would pay attention to more so. Okay, methanol. It's your favorite go-to whenever the alcoholics are kind of are withdrawing because they often have readily accessible form of rubbing alcohol, and that's methanol, right? Methanol is very, very toxic, right? It gets converted into formaldehyde directly, right? Via your alcohol dehydrogenase. Formaldehyde is formaldehyde. It's toxic, guys. It's actually precancerous. That's how much harm it can do. If you drink a lot of it quickly, it can actually lead to blindness and death because it's basically a toxic metabolite. So a lot of people will just show up to the emergency department and say like, I kind of chugged either methanol or like, I don't know, cooling fluid, and that essentially will get them to get, like the doctors back in the day would actually give them a whole bunch of regular alcohol to kind of competitively inhibit this alcohol dehydrogenase from converting more of the methanol. Antifreeze, there we go. I was like trying to form the words for ethylene glycol in my head, but what happens is that ethylene glycol is antifreeze, right? Typically the buzzword for this or like the question stem is like a kid goes into a garage and drinks something sweet. That sweet is essentially the taste that you get with ethylene glycol. The glycol component of it actually hits the right taste receptors and makes it taste like you're drinking Kool-Aid. Don't do this at home. It's not a fun time. Ethylene glycol gets converted into glycoaldehyde, and glycolic acid is pretty much renotoxic. It will mess up everything from the glomerulus all the way to the tubules to everything. It's essential death. And this can be presented with metabolic acidosis with high anion gap. Okay, you guys covered high anion gaps back in the day, but I'm gonna go over it a little bit. But when we go through this pathway, you need to know your formeprazole, okay? This is an overdose drug for methanol or ethylene glycol poisoning, okay? Know it very well. Sweet taste of death. Don't tempt me, guys, don't tempt me. Okay, methanol toxicity, okay? I told you guys it can lead to blindness. Ethylene glycol buzzword is destructive calcium oxalate. That's something to note. And typically the sweet tasting stuff in the garage. Okay. Anion gap, important for the entirety. I would spend some time learning these because they can give you some hints in the question stem as to what to know. Anything in terms of pH less than 7.4 and a reduced bicarb level is telling you there's a high anion gap. High in terms of there's large difference from the 12 milliequivalents per liter to something much lower. Okay, keep that in mind. Vitamins, my favorites. Americans have the most expensive type of urine in the world because we take too much of these, and it turns out we need like very small amounts anyway. Okay, fat soluble ones are the first essential ones we need to keep in mind. ADEK, okay, ADEK. That's how you remember it. In terms of fat soluble, water soluble are less ones to worry about, but I do want to point out a couple of things. B12 is actually stored in the liver for up to 3 to 4 years. Okay, B9 is stored for about 3 to 4 months. Okay, those are the ones to keep in mind. Those are the little exceptions. Everything else gets washed out very quickly. That's why if you have like a whole bunch of vitamin C, you don't suddenly show up with hypervitaminosis into the emergency department. Whereas if you took too much of your ADEC vitamins, you could potentially get into a lot more trouble. Okay. Now, the sources of vitamin A, very simple. You can get it from your vegetables and fruits, okay? This is why my mom always tells me to eat carrots when I was young, so I don't wear thick glasses. It never worked out, Mom. I don't know what to tell you. And what essentially is beta carotene, okay? Beta carotene, they will ask you this question. I got this question only right because I looked at this slide. It's really important in vision and rhodopsin, okay? It's really important. Rhodopsin is super important in the rods of your eyes, which are really important in seeing nighttime. Okay, really, really important. It's a very much a buzzword. I would highlight it, star it. I don't know, throw some sparkles on it. Deficiency of vitamin A, right? Typically the fad diets, right? Like when folks like are like trying to cut out all the fats in their diet, like you can also have it with any sort of fat level malabsorption, such as with like your Crohn's disease, cystic fibrosis, obstructive jaundice. There's all sorts of stuff in terms of malabsorption. Now, buzzword for this, dryness of the conjunctiva cornea. This one, they even threw in the stem and I had no idea what I was looking at. But the only reason I got it was because of reading rhodopsin, but Bitot spots are in the eyes. Okay, so these are like little spots that appear in the scleral component. So use that to your knowledge. Clinical use, typically treatment of dietary deficiency. There's not like too many implications other than like it helps with immune boosting. So you know how back in the day they're like, you should take a shot of vitamin C and like, it's really doesn't just because you chug some vitamin C doesn't mean that your immune system is magically going to get better, but they do have antioxidant properties because they take any sort of free radicals that are floating around and put it in a cyclic nature, and then eventually it can be excreted out in the urine. So they're lipid soluble antioxidants along with vitamin E. Okay, so remember, antioxidants are your aces in your hand. Obviously, you guys, any of you who have experienced any sort of acne level issues, retinoic acid is very common. There's a topical treatment for it. And you just don't give it during pregnancy because it's a teratogenic component. So vitamin A can cause teratogenic kind of developments. You guys learned that in ER. It's a good one to kind of remember for your cumulative questions. Hypervitaminosis A, most often it doesn't happen, but it can be dry, puretic, itchy skin. It can be peeling. You can have headaches. You can have benign intracranial hypertension. Obviously, you don't want to give it during pregnancy, like I mentioned, right? It's a teratogen in high levels. Okay, now let's talk about vitamin D. This one's one that's made endogenously. Guess what? 7-dihydroxycholesterol. Really, really important, right? That's at the skin level, at the epithelia, and it converts it into cholecalciferol. From there, it goes to cholecalciferol in the liver. So if you have any sort of liver damage, you can actually have your collagen level, you can have decreased calcium levels in serum as well. I'll cover that in a bit. So what enzyme gets messed up? It's 25 hydroxylase. How I like to think about it, Obviously, if you skipped out on being 21 and drinking, your next best number to remember is 25. Your mid 20s to chug some alcohol. So that typically tells you liver issues. Okay. Now you convert 25 hydroxycholecalciferol into 125 hydroxycholecalciferol. And I like to think your kidneys are going to be super involved with this because one hydroxylase is upregulated by parathormone, which is your parathyroid hormone. And it's typically stimulated by low calcium levels. Okay. This is all your ER concepts. Know these like the back of your hand. Okay. Vitamin D deficiency. This is really important. Frontal embossing. Okay, guys, don't diagnose them with achondroplasia, please. They just have vitamin deficiency. They need to get plenty of sunlight. Especially it's often seen in elderly. Nutritional deficiencies, risks that you need to remember in terms of disorders, rickets, right, for children, and osteomalacia for adults, right? Bowing of the leg, pigeon chest deforming, all that buzzwords. Osteomalacia, like I said, guess what? Serum alkaline phosphatase, ALP, is going to be elevated, whereas your serum calcium phosphate is going to be low because ALP is helping to break apart your calcium and phosphate levels. Hypervitaminosis D, guess what? Those beautiful arteries and veins and vessels that you have, they all get turned into calcium. You're going to look like Medusa when she got frozen, and it's not a good time. I'm just kidding. No, but seriously, though, your hypercalcemic states can lead to calcium deposits in your soft tissue. That's bad, right? You don't want mineralization of your soft tissue. Not good. It can lead to a lot of pulmonary as well as systemic presentation. Vitamin K. The important thing to know with this is this. Gamma glutamyl carboxylase, hella important, right? It helps in your coagulation cascade. But whenever you guys are thinking of this, my go-to mnemonic is 1972. Okay, if you know 1972, those are the things that are messed up with vitamin K deficiency. Okay, those are the factors, prothrombin factors that get messed up. So that's why I'm saying 1972. Okay. Your warfarin, you don't need to know fully well. You do need to know your VKOR. Okay, that is a given. Okay, VKOR inhibited vitamin K epoxide reductase. Buzzword heavy. Deficiency, hemorrhages. What we typically do is in kind of routine kind of cases, since the baby doesn't have the activated enzymes needed for this, you typically give them a shot of vitamin K so that these babies don't start bleeding out because they don't have these coagulation cascade kind of factors, and you don't want these babies to have some serious issues. Deficiency, risk factors, fat malabsorption, because remember, we're talking about your ADEK, right? So A, D, E, K can be potentially messed up. Prolonged use of broad spectrum antibiotics, because your gut flora gets messed up and you can't really bring in a lot of these things. Laboratory test, INR, okay? INR, very important, and the international kind of scaling for it. Hematuria, melania, and ecchymosis, as well as bleeding from the gums, buzzword heavy. Okay, bleeding from the gums can also be vitamin C deficiency. So don't get it twisted. You got to make sure you read the question stem for vitamin C deficiency as well. Vitamin E, once again, fat soluble. Most of the time they talk about vitamin E in terms of its antioxidant properties. So that's basically it that you need to know for that. Your water soluble ones are the ones that are heavily tested, guys. They're not going to tell you to give them the exact vitamin that's deficient. What they're going to ask you is more so, have you potentially lost any sort of enzymatic activity based off of if there's a thiamine deficiency, if the patient presents with Wernicke-Korsakoff, like what enzyme is going to be downregulated. Like that's how they like to ask these questions. It's a little bit more higher order than they taught in lecture. So make sure you guys practice this. Vitamin C, ascorbic acid, guess where you're getting from? Your lemons, your oranges, so on and so forth, right? Ascorbic acid. Okay, scabies, you guys know this till death. Like I swear you guys have covered it like with Dr. Trotz in term 1. All you need to know, bleeding gums, loose teeth, just think of Jack Sparrow and an image should pop into your head of like your typical like scurvy case, okay? or any pirate in general. I just prefer Jack Sparrow. Okay, vitamin B1, thiamine deficiency. You guys got to know your other names for it, thiamine pyrophosphate, because they can give you both. Keep in mind what enzymes get messed up, right? Your PDH complex, alpha ketoglutarate dehydrogenase. Most of your dehydrogenases get messed up. So tender loving care for Nancy. Transketolase, right, is also using thiamine as a cofactor. B1 supplements are typically seen to help with maple syrup urine disease. I would go over those in terms of dietary kind of protective factors. Okay. MSUD, I told you guys, once again, branched chain keto acids, right? This is the maple syrup urine disease. So if you smell maple syrup, give them some thiamine. They hopefully should be okay. Now, thiamine deficiencies are berry prone. So if it's just a dry berry, there's going to be more like sensory components that's lost, as well as motor. When there's wet is, think of it as in terms of the cardiovascular system. So the heart failure, patients, and all these things. Laboratory tests, low erythrocyte transketolase activity and serum thiamine levels are just going to be non-existent. Guess what? Wernicke-Korsakoff, like how I feel during most of these reviews, I'm going to be confabulating. I'm going to be having nystagmus activities. I'm going to be ataxic, which is just sitting there confused and pretending to know things. And then loss of memory, how I feel 90% of the time going over DM. And confabulation is just like you making up wild stories. Just kidding. That was me making up wild stories. So a little bit of humor to keep you guys going. Vitamin B12 is riboflavin, okay? I don't know. I always like saying riboflavin with an accent, riboflavin. It sounds so fancy. Coenzyme form of flavin. So what you need to know is specifically the riboflavin part is involved with the flavin part is FADH. So that's how I remember riboflavin, FADH. It's really darn important in the oxidative reactions of the TCA, beta oxidation, succinate dehydrogenase, PDH. This is the whole tender loving care for Nancy, right? Riboflavin deficiency. This one is really important, guys. If there's any sort of cracking and fissures of the angles of the mouth, this is a huge giveaway. It's a riboflavin deficiency, right? Glossitis can also be a buzzword, and facial dermatitis is like a really broad term. So don't even think about it. Just stick to these two, glossitis and sort of cracking at the lips level. Niacin, okay? This is Nancy. You can't forget Nancy. Vitamin B3 is coenzyme NAD plus and NADPH, okay? Really important. Once again, dehydrogenases, your HMP shunt, fatty acid, cholesterol synthesis are all implicated in this. So you've got to have this in there, right? It's also implicated in inhibits adipose tissue lipolysis and reduces free fatty acids. So type 2B, hyperlipoproteinemia. So therapeutic use is also important. Okay, guys, niacin deficiency, 3Ds, okay? 4D is really kind of problematic because remember, that's way too much. Pellagra, buzzword, dermatitis, diarrhea, dementia. Know it very well. Okay. Tryptophan, precursor of NADH. Remember, we can actually make NADH endogenously. So this is a path that you can upregulate. So, but like a serious deficiency of niacin can be problematic and can lead to pellagra, right? Typically, you know, if a patient has only a corn-based diet, this is huge. I would underline this because there was a question on our exam about corn-based diet, and I couldn't remember for the life of me what specific vitamin was messed up or what amino acid I needed. Heart and nut disease, I told you guys you need niacin supplements. Carcinoid syndrome, guess what, guys? Carcinoid syndrome, you have excess conversion of tryptophan to serotonin. You covered it in the, I believe in ER module. So it can also have downstream effects on the gastrointestinal system as well. You can have increased motility with serotonin, and like you can have diarrhea and all sorts of other things. B6 is pyridoxine. Need to know this cold because B6 is involved with your the really important questions they were asked us with pyridoxine was with your urea cycle, right? Your AST, ALT, how you're shuttling over all these nitrogenous groups. So know that very well. You also need to know that it's involved with ALA synthase, right? Because in the heme pathway. B6 is more implicated in a lot of ones. So just know that this is a very highly tested vitamin. Okay, what did I tell you? B6, microcytic anemia, peripheral neuropathy, cardiovascular diseases, seizures. Okay. Just a fun fact, anti-tuberculosis med, they used to give it a lot more back in the day when a lot of people had TB, and this would basically not have any sort of issue with, well, B6 wouldn't be sufficiently activated, and the B6 supplements were not administered on hand, and a lot of patients had a lot of B6-like presentations that you guys saw about microcytic anemia, peripheral neuropathies, and cardiovascular diseases. Biotin, something my mom tells me to take every day, but I always forget. Carboxylation reaction, multiple carboxylase deficiency. It's also helped with the whole, like, sometimes like with hair loss and dermatitis. So keep that in mind. This is really helpful. But what you do need to know, and what they asked us during the exam, was Abaden. Okay, this is very buzzword heavy. If a patient comes in, bodybuilder, only chucks in egg whites, it's basically inhibiting biotin absorption. Avidin basically competitively inhibits this, and biotin just gets lost in the digestive tract. Guess what? Folic acid, folate, you just need to know it. Remember, B12 deficiency versus folic acid deficiency. As always, B12 presents with neurological and increased methionine, methylmalonate in the serum and urine. So just keep that in mind as a differential whenever you think of your macrocytic anemia, macrocytic megaloblastic anemia. Keep this in mind. As always, elevated homocysteine level. If it's only homocysteine elevated, then it's typically folic acid, right? And no neurological presentation, folic acid. Okay, folic acid deficiency, typically maternal. Methotrexate is often one that's implicated. This is something you're going to learn later on. So neural tube defects, keep that in mind. Macrocytic megaloblastic anemia, keep those buzzwords in mind. Okay, B12 cobalamin. Here's the thing. Cobalamin is found typically in your red meats. So often it's an implicated one in your anemias with vegetarians. As someone who's a vegetarian, I've personally seen this struggle way too many times. Luckily for me, I don't know, maybe my B12 just hangs out for more than 3 to 4 years. So no anemia here. God bless genetics. Okay. Vitamin B12, cobalamin, once again, methylmalonyl-CoA mutase. If there's a deficiency, there's going to be increased levels of methylmalonic acid and a lot of neurological presentation. B12 deficiency. Keep this in mind, guys. Make sure you guys are tying those pictures in. Guess what? Intrinsic factor with B12, gastric parietal cells, any sort of malabsorption or damage with Crohn's disease or any sort of celiac disease can also present with this. So keep this in mind. They often call it pernicious anemia. So that's very much a buzzword, terminal ileum, location that they like to ask. Deficiency of vitamin B12. I told you guys all these factors. Remember neuropsychiatric symptoms. So that's due to the methylmalonate activities. Once again, here it is, macrocytic megaloblastic anemia, folate, folic acid, how it looks. They don't give these histo slides. I just threw that in for your information. Now, there was a DLA for you guys that covered your minerals. Not as high yield, but I will point out 2 that I was tested on, Menkes and Wilson's. Okay, Menkes disease is a deficiency in your lysyl oxidase. Remember, this is one of your collagen pathway. Remember, all of your prolyl hydroxylase happens with any sort of vitamin C, right? Whereas Menkes disease is due to a mineral deficiency, it's due to copper malabsorption, okay? You just don't get sufficient levels of copper or something, it messes it up. You can have kinky hair. I don't know how, like, that's just a buzzword for it. I don't know how it looks exactly, but it's just like circles apparently. So I'll take it. Wilson's disease is a deficiency in ceruloplasmin, right? You're not having any sort of capturing of your your broken down copper, and that can present with iron overload in the liver, and that can have neurological issues as well as corneal issues. Buzzword for this is Kaiser-Fleischer rings. So those are your copper-colored rings in the cornea. Actually in the retina. Oops, I need to make sure my eye anatomy is on point. So it's actually in the retina, and you'll see. Nope, take that back. It's still in the cornea. Looks like I'm confabulating. It's in the cornea, and it's the deposition, and you shine light on it, and you'll see the illumination right around the cornea. Retinas are further in the back, guys. My apologies. Okay, I threw this last bit in because it literally saved my butt several times in terms of what I needed to know for a couple of the questions. Iron Fist Bro. This is me giving you guys a fist bump. Or you guys watch Shang-Chi. It's Iron Fist. I'm just kidding. It's nothing related. What you need to know is that iron is absorbed in the duodenum, folate in the jejunum, and B12 is absorbed in the ileum. So make sure you guys use this mnemonic to your advantage to remember where each of this absorptive kind of these, because remember, these are all essential, right? Iron is implicated in your heme Fe synthesis pathway. Folate is for your neural tube defects, B12 with the intrinsic factors and the terminal ileum, parietal cells, all those buzzwords. Okay, I swear we're getting into the tail end of it. I'm gonna hopefully let you guys out, hopefully a little earlier than 3 hours. Lysosomal storage diseases, these were super buzzword heavy, guys. I'm gonna throw all the buzzwords at you. Okay, Hurler syndrome. Okay, this is not X-linked. Hurler, that's what you need to know. Iduronidase, dermatan sulfates, and heparin sulfates. They're also implicated in hunters, but you need to know everything in red for these, okay? And iduronidase is the one that you need to know very well. Okay, Hurler syndrome, coarse face, right? Short stature, they're gonna have hepatosplenomegaly, right? The lines that you guys are seeing here are actual physical examinations done by physicians to mark the bordering of where a normal liver used to be and now where the liver is currently and where a spleen is currently like this, okay? Very bad, very sad. They're gonna also have corneal clouding, okay? Hunter does not have this because hunters are really good. They shoot straight, right? Think about it this way. Hunters with good eyesight will catch aggressive chupacabras active in Texas. So it's X-linked recessive, affects males predominantly. Iduronate sulfatase, I can't pronounce these. And no corneal clouding, no corneal clouding. This is very buzzword, okay? Know that very well. You can also have these Mongolian blue spots. They are not often thrown in there, and it's very buzzwordy. So they typically just give you no corneal clouding and enzyme deficient that you need to know. Tay-Sachs disease. After they hexed Tay-Sachs, his plane became deficient. That's how I remembered it. It's hexoaminidase A deficiency. GM2 ganglioside accumulates, right? Neurodegenerative typically, and developmental milestone delays. They're going to tell you guys more about those in NB. Okay, no hepatosplenomegaly. Okay, this is very important. This is the way you differentiate Tay-Sachs versus Niemann-Pick's. Okay, they have very similar presentations. They're both autosomal recessive, but no hepatosplenomegaly in Tay-Sachs. Okay, also buzzword onion shell inclusion. Okay, onion shell, you can guess with 90% confidence that it's Tay-Sachs. Okay. Gaucher disease. It's a sweet disease because they have glucose ceramide. It's how I like to think about it is they have neurological presentation. They have bone crises. I like to think, I don't know why ceramide reminds me of bone. What is deficient is beta glucosidase, right? Everything just sounds glucose. So I watched a couple of picturized videos and that helped me kind of remember this. But if you ever see crumbled tissue paper, it's Gaucher's disease. Don't even trip. That's how I got like a good chunk of the answers for this. The other buzzword for this is Erlenmeyer flask. So crumpled tissue paper, Erlenmeyer flask, know it very well. It will also present with hepatosplenomegaly. Okay. Fabry's disease, globoside. I just remember the farting babies. I don't know if Dr. May kind of covered this with you, Dr. May or Mai. I'm sorry if I mispronounced her name. It's alpha glucosidase deficiency and it's globoside, right? AKA ceramide. Just know this very well. Yep, farting baby images. It's infamous. It's kind of like the highlight of the DM module. That's what I was looking forward to. Fabry's disease, globocyte accumulates in the skin and kidneys and nerves and heart. Okay. Once again, buzzword, foamy urine, right? Alpha glucosidase A deficiency. They're gonna have like a kind of really sweaty or dry, and it's typically males that are affected. Niemann-Pick's, okay? Sphingomyelin. This is what's implicated. What's messed up is sphingomyelinase. So what gets accumulated? Sphingomyelin. That's it. Very simple. This is the one that you're going to have cherry red spot. So both Tay-Sachs and Niemann-Pick's have cherry red spots. What differentiated this versus Tay-Sachs is the hepatosplenomegaly. Very, very useful. They're both autosomal recessive. This is foamy, okay? Remember, Tay-Sachs is onion skin, Niemann-Pick, foamy. This is so buzzword heavy, guys. I can't even talk straight other than just give you guys the buzzwords that you guys need to know to get this right. Okay, metachromatic leukodystrophy. It's typically a deficiency with harncyl. Okay, sorry, I can't pronounce this. Aryl sulfatase A, and typically what accumulates, it's sulfatide. They don't typically ask this. It's a very severe disease, and most of the time patients pass away. Guess what, guys? Pompe is back. Now, this is a lysosomal storage disease as well as a muscle glycogen storage disorder. So it's in multiple categories. So you best believe you need to know it well. So buzzword, acid maltase. If you see it, it's 1,4-glucosidase. Typically, what's going to be messed up? Your heart, muscles, kidneys, and liver, due to the fact that the lysosomes are constantly tapering your glycogen stores and cutting them down so that they don't excessively accumulate and have damage of any of the organs. Okay, I cell, inclusion cell. It's a very simple. It's the primary pathogenic pathway is that the mannose-6 phosphate marker isn't being added to your cell, or sorry, to any of the particles that are being generated that needs to be degraded. So without the mannose-6, you can't do lysosomal degradation of this. So you're going to have excess levels of glucose aminoglycans and sphingolipids in the lysosome. Remember, I cell is just inclusion cell. I threw in a nice table from AMBOSS that covers all of the buzzwords and all of the lysosomal kind of diseases that you guys have gone over in terms of what will accumulate and what will just remain normal, as well as the inheritance pattern, buzzwords, etc. As always, I threw in Dr. May's little kind of table of, I don't know, mnemonics all over from the internet. I thought it was kind of helpful, but I personally had my own little mnemonics to remember things. Okay, as always, external resources. I know it's very late, but I'm telling you guys, do the McDaddy questions, do the Grace questions. The last couple of days before the exam, all I did was questions nonstop until like my eyeballs fell out. I'm pretty sure that was a neurological disorder as well. But thank you guys for coming. Wishing you guys best of luck tomorrow and today studying. You guys got this. You are fantastic. I know you guys are panicked. I know I got a lot of DMs. I'm sorry for not replying. I was panicking myself with term 4, but you guys got this. Best of luck on Monday.